Панове учасники, прошу вас уже готувати.
So ladies and gentlemen, dear participants, we'd like you to prepare. So in a couple of minutes, we actually are about to start the conference, and I'd like you to make sure that your phones are in a sleepy, quiet mode. Next to the entrance, you actually have the table, and there are some guys who'll help you with the headsets. In a couple of minutes, we're about to start, so get ready.
Good morning, ladies. I'm David Elkins. I'm the Chief of Party for the Health Reform Support Project of USAID. On behalf of the organizing committee, I'd like to welcome you and officially open the conference of Restoring Healthcare Services at the Community Level. I'm pleased to introduce Oksana Muliar, who's the moderator for today's event, and give her the floor. Oksana?
Thank you so much. Thank you so much, Mr. Elkins. Thank you. And my name is Oksana Muliar. I'm the medical communication expert and I'm a journalist. And I'd like to say congrats and welcome to everybody we have in the hall and watching us online and listening. And I do hope that you'll have continuous energy supply. You'll be able to watch all the conference. But okay, if you have any energy supply problems, the stream that we have on YouTube of MOH will be saved. And you'll be able to watch it, of course, later and just to catch everything up, all right? Okay, so before we start the event, I would love to ask you to pay tribute to those who gave their lives for independence. Thank you. Thank you, ladies and gentlemen. And now we'll speak of the safety rules for today. So we'll know what happens that if any air raid alert takes place, we're going to bomb shelter, so we stop the conference. We have a chance actually to continue with certain technical specificity, but we will discuss it upon the occasion, if it's necessary. Okay, I'd like to ask, well, I know, and I'm doing the same thing. When the air raid alert starts, we will get our phones, and in social media, we will see maybe there will be like opinion that, okay, this is like just MiG flying above us, no need to go down, but please stick to safety rules. We'll have to go down because in the hall, we have so many of us, and it will take a lot of time, so please try to understand. Okay, try to be supportive in this case. So we'll continue in the bomb shelter if something happens. So again, we have English-speaking speakers, and if you do need translation, you can actually take headsets next to the entrance. And if the light goes out, it may happen. Approximately like at noon, we'll stop for 1 minute and continue. It's gonna be fine. Okay, it's like I guess we've handled all the organizational matters, and I will remind you of this. If you need something, just ask the organizers. And okay, now let's get down to business. Okay, so the aim of the conference to coordinate the efforts of partners on implementing the integrated approach and restoring the access to high quality services in healthcare sector at the level of community. We speak of restoration, but it's not the rebuilding of walls. Well, construction experts will do that, and we speak of on how to establish a system, human-centered system. And the tool, thanks to which we can actually achieve that, is the integrated approach. Integrated approach stipulates close cooperation and coordination. And today we have a unique chance, well, again, to meet offline and to make sure that we have the same vision, that we're on the same board, and maybe just elaborate some plan on how to move forward. So our participants are the national and international stakeholders. We have donors, we have governmental officials, representatives of communities who actually shape, formulate, and implement this policy at all levels. Meetings like this actually give us a chance to check if we all are on the same page, and we actually, to start the discussion and to set the tone, I asked the participants of the first panel where we discussed the importance of integrated approach in the process of restoring the access to healthcare and social assistance during the war. I'll be your voice in the couloirs today, now. And I announced the speakers, I announced the panelists. The initial panel. Okay, we have Viktor Lyashko, who's the Minister of Health of Ukraine. Please.
Зараз іде засідання Верховної.
We have the meeting of Verkhovna Rada right now, and Mr. Mikhailo Radutsky, he had to be here, but I'm not sure if he is capable of joining us, but I do hope that he will join later. Yulia Sokolovska, Deputy Head of the Office of President of Ukraine. Oksana Zholnovych is with us. She's the Minister of the Social Policy of Ukraine. Okay, she'll join us later. Natalia Kozlovska, Deputy Minister of Communities, Territories, and Infrastructure Development of Ukraine. She will join us a little bit later. Natalia Husak, Head of National Health Service of Ukraine. Robin Martz, USAID Ukraine Health Office Director. She'll join us online. We have Jakub Kakietek with us as well, Senior Health Economist of the World Bank. And he's responsible for the healthcare sector, World Bank in Ukraine.
Dene Cairns.
And also Dene, who is responsible for healthcare sector, WHO office in Ukraine. Okay, so at this discussional panel, we focus on how to improve the provision of services during the war in conditions of vertical and horizontal fragmentation. We work till 12, meaning till noon, and you all have 6 minutes per speech. If we stick to timing, then it will be possible for us to discuss some of the issues that we prepared. Okay, so dear panelists, please try to build your speeches around these statements. What are stakeholders doing to reconnect the population's access to care? Stakeholders in their institutions, at their level. And how do you apply an integrated approach in this specific activity? But first, I would love to, for the welcoming speech, I'd like to pass the floor to Viktor Lyashko. You're so welcome. Thank you so much. So, dear ladies and gentlemen, stay safe. What I should start with. So my words of gratitude to all people in this room, to your colleagues, for all those wonderful, impressive achievements that you actually demonstrate for Ukrainians to stay healthy and safe. For us to have a chance to save those who suffer from Russian terrorists attacks. My big gratitude to international partners, not just those we have in the room, of course. Thank you for helping Ukrainian healthcare system to withstand. It's not a secret, I guess, for anyone that today every hryvnia of taxes, it goes directly to defense and security sector. And exclusively thanks to investment of other governments and other states and international partners, we have a chance to invest actually the healthcare sector and infrastructure and social sector. This whole thing unites us, for us to generate effective solutions and implement this. As practice shows, any effective solution without horizontal and vertical coordination, any solution without integration between sectors can actually result in wrong consequences, not something we expect to get. So I actually am so grateful to the organizers of the conference. Thank you for raising such an important issue. How to combine, how to merge all the functions, all the central executive power bodies at the level of communities, to have this integration for every person requiring medical assistance, social support, for every person to be able to use these services that exist and to be satisfied with the quality of the services provided by the state. Trust me, there is capacity to do that. The most important thing is to coordinate. Later, I will tell you some things you won't like, maybe something pretty debatable, but things that should be talked about. We have to discuss it because in the process of discussion, we always find the compromise, the solutions that actually give us the result. And we all want to get the result. Thank you. Thank you so much, Viktor. Thank you for the welcoming word, and a round of applause, please, for the welcoming speech. Thank you. Thank you so much for just setting this tone, like coordination, joint activities, something to be discussed. This actually already pushes us to some active work and results, that we can achieve today. And I want to remind you that we start the discussion. The importance of an integrated approach in the process of reconnecting public access to medical and social care during wartime. And the focus of discussion, how to improve the provision of services during wartime in the conditions of vertical and horizontal fragmentation. Every speaker has 6 minutes, and Viktor, I think you should start the discussion. Or I offer, at least. Okay, I will start the discussion with the discussion, actually. Okay. So, we were implementing so many vectors in areas, various changes and transformations that should have given some result. What is my biggest pride? And what actually showed the result? Establishing multidisciplinary teams in the rehabilitation healthcare sector. Because when we combined something that we never expected to combine, when physical therapists, ergotherapists, assistants of both, prosthetic experts, social workers, it started working differently. So we provide the assistance required by the person, and we start providing services which usually in healthcare facilities nobody even talked previously, because this was not our area. When we talk and why do we all exist? We exist actually for Ukrainian citizens to get something that they need, definitely. And if each in one sector will do something and everything will rotate around the patient, if we will start throwing the responsibility to each other or delegating, we'll lose the patient. When the full-scale invasion started, we understand now what are the consequences that someone may not see, how one can help in this specific moment or connect various sectors. We all remember 2020, the start of the 2020, mid-2020 diesel crisis, when everything stopped moving, all the transportation. And we understand that just for a person living in a remote settlement, coming to the oncological center and not be able to handle all the procedures in one day, this person will not come eventually, or will come in a certain period of time when it's too late already and a lot of pain. This will be the terminal stage, let's say, of oncology, and this is hard to cure, or it's really expensive, or it's long-term treatment. If the process was organized how to do it initially, if we did that, it would be really much more simple. And here we have a lot of things, sorry, I'm jumping to very narrow specialization, but if we had a chance for if there was a chance for a person to get some social service, including the accommodation, or if we were able to organize things like in the facility, we would not lose the person. The person would get the whole diagnostics course and maybe start the treatment at early stage. And this is one of the elements that actually I'm showing. How can we move forward at every component? So we talk about community. At the level of communities, we have so many things happening. So the first entry point and the final stage of treatment, or let's say social adaptation, rehab for a person. And here we have to understand that the healthcare system itself, which is concentrated on detection of disease and treatment of that disease, not always it will handle the load, And what we need to understand where that worker is, or the person is, that will help us actually and solve the matter, maybe something that previously did not even relate to medical staff. We speak of social workers, people who actually are able to perform those social functions. And we talk not only about Ministry of Social Policy, because we have the veterans assistance now emerging, we have more and more veterans every day, and it will increase the number. We have to coordinate this at the level of community. And we have to understand who becomes the leader, who must coordinate this. When we as an MOH, understanding that the war started, when we saw the problems, we understand how the service provision system is working at primary level, at hospital level, we give certain messages saying that, okay, this should be done, not always it's perceived adequately. by those who get the message, by the recipients, because instantly they start saying, oh, look, it's the medical guarantee program, 504 is the list of services, and it's not funded additionally. On the other hand, we realize that everything should be revised. But if there's no coordination, if we don't combine, like, these services, how to combine these, we will not achieve the result. So at the level of, at national level, between Ministry of Social Policy, MOH, Ministry of Veterans, committees, and Presidential Office, we are having these triplets to process solutions, then put it from top to bottom to make sure it works. I'll have a request to you. Please try to handle it all and discuss it at conferences to offer the algorithms where you see gaps, in our cooperation. Where can we refer anyone, or where to call to get the result? A typical example, we launched in the framework of this national mental health program, the YAK, How Are You, initiated by Ms. Olena Zelenska, the First Lady. We launched MHGAP, and we asked family doctors to be engaged to get some training, pass the course, and help to identify problems related to mental health and help at initial level actually to handle those. But certain things emerge when family doctor says, I can't do it further. What I know, it doesn't help. The problem is where to refer. Usually medical sector, healthcare sector will refer to healthcare sector. So we will refer to a higher level, to a cluster hospital where there will be a psychiatrist, psychotherapist, maybe a psychologist. But we can't, we may not even know that somewhere close there is a resilience center close to it. Yes, with qualified psychologists already who can actually handle those problems, clinical psychologist, and one would do it really fast. The person would never even leave the community, and one would handle that, locally. The same thing may be with a rehab. When a person had some inpatient rehab sent to community, quite often we don't know at the level community that patient even emerged, that person is in the community. And maybe the primary level may actually provide outpatient rehab. All conditions are there. And social service will be provided to this patient. But will this patient be referred or, let's say, led to the primary level where the service is provided? A big question. Okay. In some communities, it's perfect. In some communities, everyone is standing on one's own. This conference is happening to merge our efforts, okay? Understand where can we be useful for each other, and how can we actually start tomorrow living and working in a new way. Thank you.
Thank you, Mr. Minister. Indeed, some part of our conference is dedicated to primary health care. We will cover the issues related to the operation of nurses and doctors. But now I would like to introduce the Minister of Social Policy of Ukraine, Minister Zholnovych. Now I would like to give floor to Ms. Yulia Sokolovska, the Deputy Head of the Office of the President of Ukraine, as a continuation of our discussion. Good morning, our dear colleagues, friends. I can see many friends here. So first and foremost, I would like to say that this event is actually a bullseye, because different ministries, partners, donors, all stakeholders are dealing with one and the same matter, or everyone is coordinated and everyone understands the direction we should follow. So during the war, during these hard times, I believe it's critical to join efforts, not to waste energy for lower priorities and not to stay focused. So I'm proud of being able to get together here and to discuss a lot of important issues. As for the integrated approach, multidisciplinary teams, all these words just warm my soul, because I try to imagine the role of each stakeholder in that integrated approach, and probably it is not obvious what exactly the Office of President is doing. My strategy of work is integration. I know for sure that the Minister of Health knows what social services are, what detection means, so many other things that probably he wouldn't be well aware of. Same with the Minister of Social Policy, as she knows about the basic benefit package, knows what PMG is. And these are not just the executive decisions. That's the quality of life of people in a community, basically in any entry point. And I'm really grateful to Minister Lyashko because he took over the leadership and he wasn't afraid of making the entry point for a person a healthcare system. And I understand that it means more workload, more authority on the ground, more stress, more responsibility. But at the same time, we understand that we need quality tools. We have to look at financing system. We have to move along positive, innovative approaches, but at the same time, we should retain health workforce. And another important thing to me as an integrator, as a manager, because of war, we need to think how to save human capital. I'm afraid that with time, we might have lost some human capital. And right now, we cannot lose anyone, any person wounded or injured during the war. We have to invest in the quality physical and mental rehabilitation systems at all levels. We have no right to lose anyone. We had situations when the healthcare system provides one numbers and the social ministry provides us with other numbers. So, for example, when a person is discharged from hospital, it doesn't mean that the person is receiving social services now or receives prosthetics or any other kind of support that is needed at this particular moment of life of this person. And the creation of this quality, horizontal and sometimes also vertical tools, they will help to see a big picture and to have analytics and to develop quality policies, because during the war, we as the central executive power, we generate some resolutions, laws, we design something, we always want to improve something, but then it goes down to the community, to specific people who are supposed to implement all that. And it's important to make sure that all these tools are working and that we, as the country, could ensure quality training, quality IT products, quality processes, trying to make the life easier. So, what I mean, we have many ideas, many opinions. That's not the end. Every week, every month, we have meetings, we discuss large strategic projects to create tools for implementation at the community level, to see how it works, to launch some pilots. And I do appreciate the efforts of communities that already started the pilots. We started many pilots in the health sector. You can remember the health reform. There always been leaders and people who can take over a little bit more responsibility. And the people who show interest, who are inspired, and the well-being, the initiatives, they matter a lot, especially now during the war. We cannot stay aside. We cannot stay just in our small and comfortable box. So we have to enrich our outlook. We have to widen it. We have to make decisions. We have to be decisive and to accept everything that is offered to us by this time. Thank you for joining this meeting. I'm really happy that you have managed to arrive, and I wish you I wish you fruitful discussion and cooperation. Thanks, Yulia. Thanks for talking a lot about the communities and projects, and because Now this is like our key target audiences. Now I would like to give floor to Minister Zholnovych. I would like to update you on the focus of our discussion. So we are discussing the importance of integrated approach for restoring access of people to quality care. So please stay focused on this particular topic as we discuss how we are supposed to provide quality care during the horizontal and vertical disruptions. Thank you so much for letting me speak at this distinguished forum. Like my colleagues have said, everything we develop is going to be implemented at the community level. And if communities does not feel this coordination and collaboration, then it will be only in our heads or on paper. From our level, I believe that probably it's never happened before. I mean, that kind of synchronization and interaction between our ministries. We attend the same meetings and we spend hours discussing how to improve our coordination, cooperation, how to improve our referral mechanisms, how and what we should do not to lose any person during these referral processes. So many thanks to Minister Lyashko and many thanks to Ms. Yulia Sokolovska, because they understand this. Just imagine, to mention a social worker in the hospital 3 years ago, it was almost impossible. Why? Why do we need this person there? What is their scope of work there? And also, assistive technologies in hospitals are this kind of social support. This is the matter of social policy. These should be several separate locations for this. It has nothing to do with the health sector, but it does, because it is all about a person. Because when a person receives the entire range of services in one place, it's easier. Because, for example, if a health professional tries to restore the capabilities of a person, but this person is depressed because, for example, this wounded person is a veteran and his house is ruined and he has nowhere to go. And if, for example, this person is an amputee and they can't walk, and somebody has to tell this person that after hospital, after the treatment, there's life out there. There are such and such factories and companies. There are such and such types of prosthetics. There is such and such type of support. This helps to relieve person's mind, and it also makes the life of the health staff easier because they are not supposed to do something that is not typical for them. Again, when we are talking about the treatment and support for senior age people, do we need a special doctor for the aging population? Maybe not, because sometimes the health element in this structure may violate the rights of these people when the doctors prefer just to prescribe medicines and don't care about the social aspect of treatment and care and support for senior age people. But this is always a matter of support and care. And in addition, we are able to protect human rights. And again, this is about better quality of life of every person. Just like our interaction from the point of view of psychosocial support and interaction was presented. Of course, the doctor cannot spend an hour just listening to a client. And sometimes talking is just what the person needs, because the person wants to talk and wants to feel empathy. But the doctors have no time for that. And this is not the doctor's responsibility. This is the social worker's responsibility. We are the first link, the first contact that could help this person and probably to refer this person to the support group or something like that and help to share the experience and overcome negative experiences, because we have many like wounded people, we have many IDPs. There are many social reasons, and we have to address them, because if not addressed, they may lead to medical complications. If we do not create these support groups, then tomorrow this depressed person with some psychological or mental health disorder will enter the health system, and accordingly, we will have to invest much more to help this person recover and to bring this person back to the society. So we have to understand that health sector and social sector, they are inseparable. And it is critical that each community could ensure this interaction and this union. The healthcare system is in better condition because there is clear network, there is the health service, and there is PMG, and there are certain algorithms. Speaking about the social system, social care system, it is not that well developed, but we keep working to offer to each community a clear algorithm of actions. How many services you're supposed to have, what they should consist of, and we also have to provide IT solutions. Our social workers do not have to be accountants, but they have to work with people. They have to help people in crisis, and they have to explain to this person how to cope with that. Because we as case managers, as social workers, we have to explain, okay, here's the family doctor, this is the rehabilitation setting. We have to know that, we have to refer people, we have to work together. So that's why we process lots of tools. We prepared a draft law on a single social area. We introduce digital case management. This is something similar to the e-health system, where each social case will be managed and visible. And when we ensure the data exchange between our systems, then we won't lose anyone, because the information about the discharged person will enter immediately the social care system. And the social worker will see the information about this person. And then we'll know who needs social care and social support. Then we will have a holistic system. But of course, these plans have been partially implemented, but there is still area for improvement. And without the feedback, what is working, what is not working, how to improve, then it won't be implemented perfectly well. So I'm really happy to have this conference and to be able to speak live and to feel the feedback of the community and what needs to be done to improve the quality of it. Thanks, Minister. And I would like to highlight a word that you mentioned, the algorithm and scenarios. And we have a couple of interesting bullets. And I know that Minister Lyashko has to leave us because of the busy and tough schedule. Okay, Minister Lyashko, probably you would like to sum it up. I'm sorry for speaking for the third time within that short period of time, but we are going to discuss now the self-governance in our health sector. So that's where I have to go. What are our next steps and what is the place for our next synergies? And I'm sure that my colleagues from the Ministry of Health can explain which way the ministry is going. So first, we are moving towards a separate service, separate infrastructure, like a nursing hospital. It's a critical thing for today. We're working on it. My colleagues will join the panel discussion and will provide you with more details. Also, medical and social committees or boards, they will be eradicated and their mandate will be transferred to the hospitals. So that's how it should be, so that a person could receive all services in one place, rather than running among different legal entities. Palliative care. Not particularly clear where the social area should step in. So we plan to consider this matter at the nearest meeting of the board of the Ministry of Health. So we collaborate with the Minister Zholnovych at our internal meetings, and then we'll post our findings and developments for public discussion. Next, in hospitals the hospitals that currently provide services to combatants, they create the veterans representatives or veterans ambassadors in the hospitals. And they will inform the veterans what kind of services they could receive free of charge, so that this person, this soldier, could stay in the hospital and receive all services they need and what needs to be done after the treatment is over. Mental rehabilitation. So usually it should be done in recreational facilities with the engagement of health professionals. So we are discussing this as well, because we started from the lowest level, the community level. We try to spot all the cases to be able to provide assistance as soon as possible, but we believe that we would like to have this mental health rehabilitation in the hospital follow all clear guidelines and algorithms. So, what PHC should be prepared for? There's a growing number of substance users, and we recently considered the actions to oppose it, and the family physicians have to play an active role in that, including the social service as well.
Go to website of MOH, read the concept. There's a lot is done already. And soon, at Interdisciplinary Coordination Council meeting on mental health, we will bring the suicide prevention issue. This will be like a comprehensive concept and activity, but unfortunately what full-scale war brings us, that we have to work with that as well, of course, and not autonomously, but only as a team. And a separate issue where we move actively, we have to introduce the reimbursement. Well, it's a complicated issue, but we're moving with this. It's quite bureaucratic, but we still are moving. And I do think that if we all are there in the process, we'll get the result. Okay, yes. Thank you for having such a great platform to have the discussion and to ask, answer, and discuss. Please, don't hesitate. My colleagues will be at the panels, and they will give you all the details on the MOH activity. Thank you. Thank you so much, Viktor. Thank you. Okay, we continue with the discussion, and I'd like to pass the floor to Ms. Natalia Husak, who is the head of NHS of Ukraine. Good morning, ladies and gentlemen. Good morning, dear partners and colleagues. Well, first, I'd like to express my gratitude for organizing this wonderful event, because we as NHS, we completely agree with the idea that the person and one's needs should always be in the very core, in the center of any policy. And if we take the PMG, I guess family doctors and many of you here today know that PMG is built on the patient's needs, and it's a patient-centered approach. This is the foundation that we never refuse from. Okay, taking into consideration that, again, we speak today about communities, community level, it seems to me that just like in the social service standards, human person and one's needs are in the core of the policies of decentralization, local self-governance bodies' activities, their interaction. Again, person is the core and always will be. And it seems to me that recovery or restoration per se, maybe in some communities this is not even an issue of restoring, but an issue of actual assessment of the needs, because sometimes those things which are shaped in the under the cover of restoring or recovery, usually these would never be shaped in that specific package, because we have some community heads. We as NHS cooperate tightly with them thanks to our partners USAID. Within the recent 2 years we've been doing this, and we can see that sometimes for us to show and demonstrate or underline something which is strong or something urgent to be restored in the community for people, it's not shaped that way, okay? But the focus goes more on more competitiveness, as the heads of communities seem to, and even those services which later will be not in demand in that community. It's so important to speak of this. If you talk about the NHS packages, well, starting from the primary level and mobile palliative teams also, and rehab that was mentioned already, and many, many other packages that we have. And these in the scale have already included the mandate, the interaction of social workers and doctors. And each of you actually knows that this interaction, and we heard of that, and Ms. Yulia and Oksana and Viktor spoke, that it has some peculiarities at regional level, depending how that interaction is understood by key stakeholders who implement the package or the policy at local level respectively. So obviously we have better practices, we have communities where it's necessary to restore this interaction, but still, the very fact that it exists in PMG, that attention is focused on that, I think this is quite an accomplishment. It's a positive thing that healthcare system transformation brought to us. What can I mention again? What can I note? So last year, in 2023, it seems that there are some programs which should already become functional for people, like the affordable or accessible medicines, program. It has to work perfectly, with this program. A network is there, primary level doctors, therapists, people requiring that, but we forgot that it's important to promptly and in full scale to make heads of committees aware of that, bring this information, because the access of community residents to those medicines, to programs, it depends on their activity. If they interact with the pharmacy network, if they build or restore the mobile team network. By the way, our partners are piloting that as well in Ukraine now, and we even have in the vast majority of territories this type of service. And when we started talking to heads of communities, we saw in very tight contact, we've seen that this type of our communication gives us a chance to increase the level of these electronic receipts. We have plus 1,500, a groundbreaking number of pharmacy points which actually joined this program. Only when we started focusing the attention of heads of communities that this is important for their residents, this is important for the health of their people. And this is the case which we will... Okay, so the issue of the case that if you bring information properly, if you interact properly, all the links of the chain. I always told it to the heads of communities. Even the social worker is important in the accessible medicines program, because there are people who, as they are lonely, they don't have relatives, maybe they trust more to social workers than, for example, to their family doctors. Different things may happen. They can approach that person to the program in that specific way. So what else I'd like to note? Of course, we will continue supporting all those policies formulated by the MOH and Ministry of Social Policy, and we will implement it very promptly and efficiently to ensure that people do have a chance to get integrated service. Because we've seen that, so many times when we discuss this at various platforms with the MOH, Ministry of Social Policy, that unfortunately, despite this generalization, like the person has access to high quality services, healthcare services, we still do observe that there are some categories of people, especially in communities, that heads of communities know about that. Unfortunately, they don't have access. So in the focus, we will always keep in the focus when we implement our policies. Those people will be in the focus as well. Just to finish, when we try to create any integrated relation, or when we try to build some additional policies, complementary policies, we don't have a right to lose something that's already functional, that gives us result, something that already satisfies the needs of people in an efficient way. For example, now the veterans policy is on agenda. And we are so intensely focused with family doctors, with Ministry of Veterans, with volunteers and CSOs. For us, that when we finally structure a new policy for veterans in a new context, it's necessary to take the best that we have in social sector, in healthcare sector. And this is really important when we talk about restoration of services. Thank you so much. Thank you, Miss Natalia. Very interesting. It was a very, very interesting statement that integrated approach is actually possible and in the context of funding, yes, by NHS. I would love to ask our technical staff, do we have the online connection with our next speaker?
Пані Робін Марц.
Ms. Robin Martz, USAID Ukraine Health Office Director. She's online with us, and I hope we'll see her on the screen.
Пані Робін, наші...
Ms. Robin, greetings. Greetings. Yes, we do see you. And I pass the floor to you. Thanks.
I want to thank the Honorable Minister. I know he had to depart, but I want to thank him for his attendance and remarks. Thank you to Minister Zholnovych, esteemed panelists from the Office of the President, Ministry of Communities, Territories and Infrastructure, NHS, World Bank, WHO, dear esteemed colleagues and partners. So wonderful to be with you today. Sorry I couldn't be there in person, but I just wanted to say on behalf of the USAID mission in Ukraine, I'm really honored to join you this morning to welcome you to the Reconnecting People to Care conference. And again, apologize, couldn't be there in person. I want to start by offering a really heartfelt thank you for everyone in the room and those who are online for your continued support of Ukraine's healthcare system. Really during the last almost 2.5 really tough years. And I want to say without reservation, the United States of America and USAID stands with the Ukrainian people during Russia's unprovoked and unjust war, and we will continue to do so. So this conference is really important. It's about how to help Ukraine ensure that it has a strong, people-centered primary healthcare system at the community level. And we've heard that from a number of the speakers this morning. We all know that that is central to saving lives and improving the health of all Ukrainians. As our colleague from the Office of the President so beautifully said, saving the human capital of Ukraine is imperative. Protecting the physical and mental health of all Ukrainians is essential for the economic recovery of this country. So with Ukrainian leadership and USAID support and others, with other international partners, Ukraine is reconnecting Ukrainians to essential health services that has been disrupted by war. I'm really proud of the partnerships that we have achieved between USAID and other partners and the government of Ukraine. One is our technical assistance programs, including USAID support to the Ministry of Health and the Recovery Project Office, RPO, where nearly 2,400 healthcare facilities have received medical supplies, and Ukraine's health sector received coordinated donor funding and investment valued at 44 billion hryvnia. And so these are important resources that can be used in Ukraine's ongoing war. USAID is also proud to support the Affordable Medicines Program that Natalia just mentioned. We believe that supporting Ukraine's vision of its health sector is based on the principle of build back better. So, and we've heard this from a number of the speakers this morning, instead of replicating pre-war health systems and duplicating whatever challenges exist in the past, Ukraine, with US government support, is talking about building a healthcare system of the future, one that produces better health outcomes, and is guided by international best practices and EU standards. So as both the honorable ministers from health and social policy laid out, the challenges of Ukrainians go beyond what the historical medical model can really provide. So the importance of a multidisciplinary rehabilitation team, as Minister Lyashko pointed out, the importance of high quality psychosocial services to help Ukrainians recover and reintegrate into society, as Minister Zholnovych mentioned, are critical. So, of course, none of this can be done alone, and it can't be accomplished today or tomorrow, this month, or possibly even this year. This is a long-term team effort. And everyone here in the room and online is critical, plays a critical role in building the healthcare system of Ukraine and building it back better. We need a comprehensive, inclusive approach. We've heard the word coordination a number of times this morning, also extremely important. It also requires continued leadership from across Ukraine. So from various government agencies, local authorities, healthcare facility administrators, healthcare workers, international donors, private sector, and of course the local communities themselves. So building back better requires cooperation and collaboration. And that is what this conference is all about. We are here to share best practices, engage in constructive debate, and develop a shared vision of integrated care and restoring services at the community level. So in the past, we have shown that we can all come together to develop shared strategies on various health reforms in Ukraine. And I am confident that we can and will come together again, just like we are doing today, to form an evidence-based and united vision of integrated care at the community level. One that will help ensure Ukrainians remain healthy and resilient, thereby contributing towards Ukraine's economic recovery and prosperous future. I will end how I started, by saying that USAID remains committed to supporting Ukraine. We will continue to work closely with our partners, with the World Health Organization, our friends from the World Bank, other bilateral donors to enhance the health and well-being of Ukrainians, supporting them as they overcome the hardships of Russia's unjust war, and allowing them to play active roles in the economic, civic, political, cultural, and family life of this country. So again, let me thank you all for being here today, welcoming you to the conference. I wish a productive day today and tomorrow. Thank you again for the time. Slava Ukraini.
Героям слава, пані Робін.
Glory to heroes, Miss Robin. I don't know if you hear us, but you have the round of applause. Thank you for this super constructive conclusion. Thank you of actually drawing the line of what you heard in the panel. It's so valuable to stress on the most important thing, keeping the focus. This is itself the prerequisite for the productivity. Thank you so much. And we pass the floor to Jakub Kakietek, who is the senior health economist of the World Bank.
Good morning, everyone. I think it's a very tough act to follow. We had very important, very well-informed remarks. So it's difficult to add something. I will try nevertheless. But before I do, I just wanted to thank colleagues from the USAID for invitation to participate in today's conference, which I think is really very important. The World Bank is a proud partner of the government of Ukraine for decades, and I think now, especially in this time of need, in this time of this unjust invasion by the Russian Federation. So the bank is proud to be supporting Ukraine, and I personally am very honored to be able to be here and work with you. just a couple of thoughts on reconnecting people to services, on why integration is important and what we as international technical and financing partners can do maybe better. On reconnecting people to services, I think we know that the infrastructure of the healthcare system in Ukraine has suffered tremendous losses because of the unjust full-scale invasion by the Russian Federation. The losses were estimated at about 1.5 billion US dollars, and it will take decades to rebuild it. I fully agree with Robin and with other speakers that it's important not to just build back, but to build back better. It can mean many different things, and I think it's really important to think very hard about what it means for Ukraine now, especially as we're thinking about integration and what we can do at the primary healthcare level. To me, also, building back better is not just about mortar, it's not just about equipment. I am a health economist by training, and what interests me also a lot is how the financing, how the funding moves through the system. So I think when we talk about building back better and about integration, we also need to think about how we can use financing levers, budgets, how we formulate them, payments, how we pay for services in a way that encourages new models of service delivery that are more efficient and more rational. And since we're talking about money, I also wanted to talk about low-hanging fruit. Through our work here in collaboration with both Ministry of Social Protection, with the Office of the President, with the initiative of the First Lady, we've worked on accessibility, improving accessibility of healthcare facilities. How can we make them physically more accessible to people with limited mobility, with disability? And it turned out that this can be done quite cheaply. It doesn't require huge amounts of funding, but it's a thing that makes a huge difference in the life of a person with limited mobility, for a veteran, for an elderly person who can move well by themselves. So low-hanging fruits need to be also part of our thinking about building up better. And this brings me to my second point about integration. Why is it integration important? What is integration? To me, integration means thinking across levels and thinking and working across different sectors. And why is it important? It's important because we do all this that we do for people, for a person. And a person doesn't have sectors, and a person doesn't have levels. To deliver services, we cannot think like that. We need to think of a person as a whole. And finally, on coordination, I really want to emphasize what was said by colleagues from the Ministry of Health, Ministry of Social Policy, from the Office of the President, and by colleagues from the NHSU. The needs are tremendous in Ukraine, and it's easy and it's very tempting for us as international donors and financiers to want to respond quickly, to build things quickly, to deliver equipment quickly. But there is a risk that we can do things that do not fit the overall system and strategy. And I think this is so important, like you said, Ms. Husak, to work through the system, to support the existing system, to change the existing system. But if we work outside of the system, this is not very efficient. This is probably not the best way of helping the government of Ukraine and the people of Ukraine. For us partners on our own little courtyard, I think we are working hard to coordinate among themselves. We work through the donor working group that's coordinated jointly by colleagues from USAID, who invited us here today, by colleagues from WHO. But I think we can do better. Sorry, Robin. Sorry, colleagues from the WHO. Instead of talking and exchanging information, I think we can really develop more meaningful joint work programs to make sure that not just that we know what everybody else is doing, but we really kind of do this true coordination among ourselves. And finally, for within our organizations, we also need to work very hard to abolish the silos. At the World Bank, we have separate teams who work on health, who work on infrastructure, who work on social protection, who work on inclusivity, who work on poverty reduction. I cannot even name all the groups, frankly, and all the sectors that are at the bank. And I think we need to do more to work much more effectively within our own organizations to be able to work effectively with the government of Ukraine as the government of Ukraine is trying to establish mechanisms and models for coordinating across different sectoral ministries. So again, thank you very much for hosting me here today, and I wanted to wish everybody a very effective and efficient and productive conference. Thank you.
Дякуємо, пане Якубе.
Thanks, Mr. Jakub. Thanks for summing up, and thanks for the summary and for the support. And I'm really happy to invite Ms. Natalia Kozlovska, Deputy Minister of Communities, Territories and Infrastructure Development of Ukraine. And I would like to remind you about the need to stay focused. And I would like to remind you about the topic of our panel discussion. And I would like to remind you that our discussion is focused on how to improve the service delivery in the conditions of horizontal and vertical disruptions. Ms. Natalia, you have 6 minutes. Hello, dear colleagues. I hope everyone is doing fine. The delivery of health and social services on the territory of Ukraine now has a bit different meaning, a bit different color. Because if we speak about the system of different types of facilities, educational, healthcare, social care facilities. Well, we knew how to operate those systems. We knew about the population. We knew about the expectations from the communities. We knew how to organize the whole system, the whole approach, how to reconfigure these or those facilities and these or those localities. But that was all before the war. After the beginning of the invasion, unfortunately, we cannot approach systemic approaches because we're talking about large numbers of IDPs. We observe a changed structure in localities. We now know about more problems in communities, in occupied territories. We know about shortages of personnel, and this problem, unfortunately, is here. But at the same time, we are saying that regardless of the number of problems that we face, we have to deal with them. We have to solve them. And as the Ministry of Recovery, we have our vision, and we collaborate with the Minister of Social Policy, with the Minister of Health, with our international partners, including USAID-funded projects. We work on different areas and directions so that the communities and the government are able to provide all kinds of services, especially when we are talking about the deoccupied territories of Ukraine. The Parliament of Ukraine has adopted new amendments to the legislation of Ukraine, according to which the local authorities and the communities can develop the recovery programs. What this document is about. It means that the communities, together with the Minister of Health, Minister of Social Policy, and local authorities, can do the assessment of this or that locality after deoccupation, to assess the structure of the locality or the community, to estimate the number of IDPs there to be able to provide the entire range of services expected by the population. Because usually the people, after the occupation, when they return home, they immediately expect several very important elements. First, electricity. Second, the house needs to be restored. And number three, social services. And these three elements, they are the cornerstone of what people expect from us and what we need to provide. So together with our partners, we help local authorities with building the vision. They have to understand what they need to provide the entire range of services. As for power supply, our colleagues from Ministry of Power, together with the donors, restore this area. As for the housing recovery, you know that we launched a project that envisions reimbursement for damaged houses, and so many people received that support due to support from the World Bank, and now they can rebuild their houses. Yes, we focus on different types of support we can provide. We try to focus on priorities, and this is like an emergency approach. And one more area that we need to mention, because we cannot stop the reform once it was started. So we try to develop the capable networks so that people in the future are able to receive health services. And how this could be done and what the quality of these facilities should be, so that these facilities will be of proper quality and could provide the entire range of services. So together with the Ministry of Health, last year, we developed not just amendments, but we created new construction regulations that change the approaches to the construction of healthcare facilities. And this is an unprecedented story for Ukraine, because this document has been under development for a decade. And finally, we found the political will, so the WHO and our team have managed to create a cool and quality European document, so that the new facilities will be able to provide quality services that the population expects. So, build back better approach, that's what we try to implement. And we understand that it costs money, but we need to follow it. And we have to be very confident, because the rebuilt facilities will be accessible. Unfortunately, we have a new reality of life, and the new facilities, the new buildings have to have shelters, because now in Ukraine, it's not like the pre-war approach when we could provide shelters just for 10% of the population. Unfortunately, the current reality is totally different. We had to revise the requirements to the construction of civil defense infrastructure. We do not consider these facilities as shelters only, but unfortunately, these are the survival facilities as well. And again, as for the accessibility, what we have to get prepared for, we have to introduce the accessibility ideology in terms of the facilities, different facilities, and also we have to ensure this for infrastructure objects as well. Everybody should feel free while moving around. The people should have unimpeded access to the buildings and facilities. That's an integral part of what we call restoration and recovery. So I would like to thank all our international partners who provide all kinds of support and assistance in all areas that we need. And sometimes our partners also look at the new experience of how different approaches should be considered in other countries, because the current situation in Ukraine proves that the EU countries and the world countries, they never faced challenges that Ukraine is currently facing. So now they have to think what needs to be done to avoid different situations when the country is at war. So if you want us to expand our dialogue and understanding, you are welcome. Thank you. Thanks for the message of building back better. This is the focus of our conference. And I would like to get back to our international stakeholders and give floor to Dene, Cairns, Health Systems Pillar Lead, the WHO country office in Ukraine.
From the World Bank had a hard time in doing justice and following the talks from our previous panel members. I think I have an impossible time after the previous interventions. But no, it's an honour to be with you here today on behalf of WHO. WHO has been in Ukraine since 1994, and we've been through many different phases with this country in terms of our support. And so we understand how difficult and complicated a lot of these topics are. But it's in these events, in terms of how we bring these topics to light and challenge our assumptions and have these conversations amongst ourselves, that really brings to the forefront these issues and really brings out the best solutions for it. So I'm very, very excited to be here with you today to talk about this topic. Recently, WHO has agreed with the government on our country cooperation strategy. This is our strategy that's going to be running for the next 7 years. And I know many of you are probably looking right now at this and being like, oh no, not another UN strategy. What can we do to get past this? But please, I assure you that this one is a very important one, that we've gone out there to talk to many different communities, many different institutions, many different national and international actors to understand better about how we can support the Ukraine response, recovery and reforms moving forward. And the message is pretty clear that we've received from all actors, that an integrated approach is the key to this. But also what's even more clear is that they've been saying it for quite some time at the community level, at the oblast level and the national levels, and that both international actors need to step up and listen to this and make sure that we offer proper guidance moving forward. On this strategy, we've identified 21 key areas of what we can say is what we know inside of what is needed support inside of Ukraine moving forward. And a lot of these issues are playing out at the community level. It's clear feedback from communities that we need to invest now to mitigate the long-term issues. And already talking about topics that we've mentioned briefly by other panel members here today in terms of mental health, rehabilitation, healthcare workforce shortages, surveillance issues, environmental impacts. All these issues are going to be playing out in communities, and it's going to be critical for actors to support the community response to these longer-term interventions. And this is the key piece that WHO stands behind in terms of making sure that we separate out, in terms of our roles, our need in terms of working as a humanitarian actor in response, but also as a consistent development actor in terms of supporting reforms and recoveries. And this is a key thing in terms of that balance and conversation and coordination that happens between those areas. Because this is moving forward, there will be needs for humanitarian interventions moving forward. There will be need to strengthen service delivery from other actors. But those actors need to understand that they're working inside a system within this country, and that they need to be integrated and coordinated within those response mechanisms. And that is something that all actors, and I think for us from WHO, we need to help international actors understand this, that when they come in here with all the best intentions, that they are there to strengthen systems, because every time we step outside of that system, and Jakub mentioned this as well, we have a potential to do more harm than good. We're taking away staff from national organisations. We're taking away resources from national organisations. We're not strengthening systems within national organisations. And these national organisations are going to be the ones that are there over the longer term, dealing with issues such as NCDs, the biggest killer in this country, dealing with issues of the mental health crisis, rehabilitation. All these pieces are key. So every time we step outside of this framework, we need to be crystal clear about the consequences that has. Just on to the next slide. And while that's coming up, this is just briefly in terms of our mindset that we're trying to keep inside WHO, ensuring that we have response, recovery, reforms in play at all times, depending on the different needs that are happening in certain locations, certain parts of the country, but also acknowledging that these need to be talking to each other, and we need to have coordination mechanisms that are actually speaking to each other at all times. Because if you're doing mental health interventions in an emergency environment and you're having NGOs go out there, they need to understand what is actually happening already in that community, what is happening in terms of the mental health outreach teams that are operating in that community, what are happening in terms of the centres that are operating there, and the policy and patient pathways that are actually happening there, and how it also connects up with the social services. And this is the key piece that needs to move forward in terms of coordination. Given what we've learned over the last couple of years, how do we create a best-in-class coordination system that brings together these three elements across all these different spaces to share knowledge and to work ahead together? And finally, just a few key elements in the what we need to be focusing on in terms of key deliverables with organisations working across these three areas. They need to be engaging in the systems that have been developed. And I was very happy to hear from the Minister about the digital case management system that's also now being set up. And this is something that we need to ensure that when NGOs and others are out there, that they're aware of these systems and tools, and that they're pointing cases in the right direction so they can engage in the national systems. It's the same as the e-health system. We've got to make sure that all organisations that they're working with are aware of these systems and tools and being pointed in the right direction. And it's a key part in terms of doing no harm as well. There's a big conversation happening within this country about deinstitutionalisation, and we do ensure that in the humanitarian space and the recovery space that we're involved in that conversation, and we're not doing more harm than good in some of these areas, and that we're not strengthening some of these aspects that are happening on the reforms and recovery side. So I just wanted to put up this slide briefly because we've tried to do a lot of thinking about this inside WHO, about how we structure our own approach, because just like we talked about by a number of panel members, about how we break down those silos, which happen even within our own organisations. How do we, and when we have different skill sets as humanitarian first responders, as we have system thinkers, as we have longer term development and recovery experts, how can they all be talking to each other in the same way that can ensure the best quality of service for the patient at the community level? So hopefully just to share a few insights from WHO's side in terms of our response. But yeah, thank you very much for having me to you today. And thank you.
Thanks, Mr. Cairns. I made some notes, and I noted several messages, several words from your speech: integration, coordination, and collaboration. I believe that these are keywords of our conference as well. And also, we have 9 minutes till the first panel is over, and I believe this is a great opportunity to sum it up. Probably each of you could say a few words, a few sentences, with the opportunity to speak to the community representatives who are in this hall. So, maybe just in the order you sit, starting from Natalia. I'm not going to introduce you again, just to save some time. Please spend some time on the content. Well, speaking about what needs to be done to achieve proper quality of services, I believe it should be done in dialogue with the communities, and so that the local authorities could understand how central executive authorities could implement these or those policies. We need to have the understanding of quality dialogue between local authorities, national authorities, because we understand that the real implementation takes place on the ground. And if we are talking about the human-centered recovery, what we strive to do and how it's going to be implemented at the community level will will show how people will receive this or that service and what kind of quality of service we will have and what we need to do to ensure this interaction. Intern, right? Yes. Today, we have a big issue, a big challenge, human capital. We lack people. We have to return Ukrainians. We have to bring them back home. So, and we will have to welcome people who are going to become our citizens, because then the schools will be empty. There will be no sense in restoring and rebuilding hospitals, and it will make no sense to rebuild the infrastructure, social infrastructure. So I would like us all during this conference will understand and remember that the community is the place where everyone wants to live. If there is no friendly environment in the community for IDPs who are often stressed or depressed, if the community will not have people in poverty, or probably have some parenting issues, or there are people with disabilities, or someone perished in the family. So if an individual feels lonely in the community, no matter how many ramps or benches you have in the community, nobody will use them. Nobody will use your perfect roads. So when you plan your budgets, when you build your policies, don't do it based on some material things. Build them based on live human being needs, because the more people you have, the more resources you have, the more you're able to do. But if people do not feel comfortable, this will be just dead localities. Thank you.
Miss Yulia, yes, I think that with two sectors, I'll mention both. Okay, so the first thing I really like, as Ministry of Social Policy builder concept, capability instead of dependence, okay? We all have to do it in such a way for people to be capable economically, with participating in social activities, mentally satisfied even despite the conditions. And for all our systems, why I love my systems that I'm handling, I mean the healthcare and social sector, why I love these? Because these are powerful sectors that actually give a chance to people to recover, restore, and again, become economically active and self-sufficient. I don't think that something can be better when we feel healthy, needed to our families, and etc. And I don't want us to underestimate the role of our sectors in life of each person. First. Second, I also would love, just to think about, like, horizontally, I do feel that we have this horizontal coordination with international partners, with the government, with ministers and ministries and other executive agencies. Okay, I want to ask communities and international partners. We need more of communication. We need high-quality tools, something that exists in our imagination, something that we design, something that we envision, and something that we plan for all that we even put in our legislative acts, how to bring this idea in the best way to the communities. For this engagement, for this vertical integration that was mentioned to be there, we need tools and we need measures. I would be so happy if we all start thinking of what quality tools can be there for this communication interaction, not just to push these decrees down like millions of acts and other papers, but for us to be able to explain, launch trainings, have various educational programs, just communicating and responding to feedback. Apart from horizontal coordination and interaction, please help us to build all together the vertical one, the vertical communication. Thank you for putting this in practice. Yes, Natalia, I was thinking now, like your question on like horizontal connection and relations, and when any horizontal connection is lost. I thought purely of our medical system, of healthcare system, because it's a complicated structure. We have PHC, we have the specialized, we have dependence on cooperations, but still, we have this discussion because we understand that all the system managed to withstand in the toughest time ever. They managed to withstand at the expense of what? Because we promptly formulated policies, people-centered policies for people's needs. You know, just one element, everybody will understand me, all the family doctors. We got rid of this Soviet system, meaning that every person can pick freely a family doctor or get some assistance extraterritorially. Imagine this. On February 22nd, when, imagine, healthcare system functioning in a Soviet type. Just try to imagine this. I'd like to express my gratitude because I can see that we have so many doctors, you know, invited who, within these 2.5 years, are staying in quite dangerous territories. I mean, now the territories which were under occupation, those even now under constant shelling, but doctors stay in touch with their patients. And we can see it, the e-health system showing this already, and we can see that when a person fleeing the occupied territory still has a chance to call a doctor in occupation. Okay, so, and getting the services thanks to solidarity of the healthcare system, thanks to horizontal connections of the healthcare system, any person can get the service. So this is priceless, truly priceless. If we refer to the heads of communities, if we, like my colleagues, if we maybe, for us to give some offer. Healthcare reform, the transformation of system, it took place simultaneously with decentralization. I call this all the time like, it happened so. It was like our destiny, you know, it's irreversible. It only has to strengthen each other and complement each other. The key value of the reforms that again and again, human in the focus, needs of people in the focus, people-centered. We can see some challenges and mistakes with the healthcare reform. We see that. Quite often, initially, interaction concept was lost in system. Instead of interaction, quite often they use the word competition. We have to recognize this because all medical facilities, all healthcare facilities started competing for patients, competing for better equipment, competing for funding. And simultaneously, just like communities, they started competing for the capacity to compete, okay? As Oksana mentioned, benches, rows, and etc. Now it's time for both, for all of them, not even both, for all of them. Okay, let's have this competition taking place in the interest of people and for cooperation. Thank you, Ms. Natalia and Jakub.
Very, very quickly, I think we've run out of time. I really like Minister Zholnovych's point about human capital and the fact that communities really need to be places where people want to live. I want to take that thought a little bit further, I think, as we talk about integration, as we talk about expanding the role of people providing services. I think it's also really important to think about creating conditions when providers want to work. We already have a massive shortage of doctors, of nurses in Ukraine. This will continue, and this may become more acute after the victory, when traveling, when moving for people may become easier. And that's why we need to think about how we can create conditions. And it's not just about money, it's about a bunch of other things as well, that nurses, Ukrainian nurses would want to stay and work in Ukraine, that Ukrainian doctors want to stay and continue working in Ukraine, that Ukrainian teachers want to stay and work in Ukrainian communities. I think this is important. This is something that is a lot on my mind these days. Thank you.
Дякуємо, пане Дене.
Thank you, Mr. Dene.
Of the humanitarian development reforms conversation. There's a lot of donors out there that are rebalancing, looking at what areas they'll be funding in humanitarian, and then also on the longer term multi-year fundings coming piece. So because of that, we need to have a stronger coordination mechanism. There's usually within the humanitarian community, a very big emphasis around the coordination elements, especially within the cluster systems and these things. But specifically in Ukraine now, we need to be looking towards 2025 and 2026 about what is going to be replacing this, what is going to be bringing a lot of those actors into a space that we can have a conversation with them on the development side, and making sure that we use their resources in an appropriate way to ensure that those linkages are there with their programming to government interventions, but also that their interventions, like I've talked about before, are not doing any harm as well. I think this is going to be key, especially on the human capital element, in terms of how we're building out the labour force into the future here, and to make sure that organisations are supporting that who are temporarily here, who are here as international NGOs and international organisations, that they're not taking the human capital out of these organisations, but building back into them and working out how to implement with them. So I see it as a really critical time to get that balance right, and to make sure that we have the right fit-for-purpose coordination systems that share information, and very complicated information, to a range of actors, and it has those accountability mechanisms in there. So yeah, but thank you very much.
Дякую. Я з вашого дозволу.
Thank you. If you allow me, I will allow myself to reflect on what we've talked about. Okay, what we observe is single vision and mutual understanding, because you've been talking about basically common things and similar things. Later, we'll have more specialized discussion on how to put it in practice. But what we can see, single vision and mutual understanding. And I have a couple of organizational things to mention, ladies and gentlemen, dear panelists. Organizers would love you when you go down the stairs. There's a registration desk. Please put your signatures. Just don't forget to do it. It's really important. And all of you, ladies and gentlemen, if you miss that chance to put your signatures, please, we have some lovely ladies standing there. Just don't forget to do this, okay? For everything to operate it best. Okay, I have some good news for everyone. We have lunch. And yeah, we go directly to the first floor. On the first floor, on the door, you'll see London and Paris. These doors will be open, but not to London and Paris, but to lunchroom. And people will give you some instructions where to go. Okay, while you're leaving, if we have a raid alert, you go to bomb shelter, floor -1. You have all the guidelines there. Enjoy your conversations. Don't lose time, and continue with discussions. We'll see each other at 1 p.m. And if I say 1 p.m., it doesn't mean you can be late, so we have to stick to our agenda. Next panel starts at 1 p.m.
спеціальностей, які співпрацюють між собою. Основною метою їхньої взаємодії є надання людиноорієнтованої та комплексної допомоги й підтримки орієнтована мультидисциплінарна команда. Відповідь на це запитання дуже проста. На тих, хто потребує комплексної, безперервної та доступної допомоги. Це можуть бути і дорослі, і діти, а також люди похилого віку. Однак інтегрована допомога є особливо ефективною для людей з комплексними потребами. Для чого різним фахівцям об'єднуватися разом? Об'єднання зусиль навколо потреб людей сприяє утриманню їх у системі допомоги, вчасно надати медичну допомогу, успішно завершити лікування, попередити виникнення складніших проблем зі здоров'ям, посилити прихильність людей до системи охорони здоров'я. Адже поняття здоров'я є комплексним і включає не тільки фізичне здоров'я, але й ментальне та соціальне. Як створити успішну мультидисциплінарну команду? Для цього недостатньо просто залучити кваліфікованих фахівців. Передусім, вони повинні бути об'єднані спільними цінностями та баченням. В команді має панувати відкрита атмосфера, яка базуватиметься на взаємопідтримці та допомозі, прагненні постійно вдосконалюватися. Результатом діяльності такої команди буде комплексна, безперервна та доступна допомога для тих, хто її потребує найбільше.
Панове, будь ласка, займайте уже.
Ladies and gentlemen, please take your seat. I give you a couple of minutes.
Та наче все добре. Чи ще щось треба? Я ж по технічному все сказала усіх.
Так, ви все сказали.
Це в кінці.
Це в кінці, так. В кінці дня. Це як людей.
Давай повернемо місці. Я хочу ти побачити. Панове, я думаю, ми через 2 хвилини.
Ladies and gentlemen, I do hope we may start in 2 minutes, right?
Тоді, будь ласка, займайте ваші місця.
Please take your seats.
Панове, цілих 5 хвилин ми збиралися з вами.
We needed 5 minutes to get together, to get back to the room, but that's okay. So let me announce the beginning of the next panel session.
Панове, чи потрібна ще хвилинка?
Ladies and gentlemen, do you need 1 more minute? Because I can hear you talking a lot. Not in the first rows, because I can see the panelists waiting in the first row, but those in the back of the room, I can hear you talking. So, our next panel is about the coordination of the efforts of projects in recovery, and we discuss the accomplishments and progress of USAID-funded projects. So, I would like to invite the panelists. First, health reform support implemented by Deloitte. David Elkins, please take your seat in the panel. Applause, please. So, 7 USAID projects will take part in the discussion. So the next participant, USAID Public Health System Recovery and Resilience activity implemented by PACT. Alyona Gerasimova, please take your seat.
Проєкт Health
Next
Link.
one, Health Link project implemented by 100% of Life. Vitaliia Trokhymets, please.
USAID підтримка.
USAID-funded support TB control efforts in Ukraine activity implemented by PATH in Ukraine, Gunta Dravnice.
Проєкт інновації для подолання епідемії ВІЛ. Ще один проєкт.
Another USAID-funded project implemented by USAID. Oleksandr Komarida, please.
Річ 95.
Reach 95 project. USAID Re-Envisioning Excellence and Accessibility in Clinic-Based HIV Services, implemented by PATH. Tetiana Horobec, please. Next, USAID project implemented by Momentum, Wheels for Humanity. Alina Tereshchenko, please.
Панове, працюємо годину.
So we have 1 hour. Each speaker. We have Q&A format. I will have 2 questions to each of you. And you will have 6 minutes each to answer them. So please follow the time limits. Because we would like to hear the questions from the hall. And please, dear audience, pay attention and ask questions. I do hope that we will follow our time schedule. So let us begin. And my first question is to Mr. David Elkins. So please tell us about the HRS initiatives and activities for recovery. That's my question, first question.
Don't be so critical. Thank you, Oksana. And thanks very much for this important question. It's especially important, I think, for this conference to speak about this important question as Ukraine's recovery during this very difficult time. Since 2018, the USAID Reform Support Project has played a key role in helping the government of Ukraine to design and drive health financing reforms in primary and specialized healthcare and advancing reforms in other areas of the health system. In the immediate aftermath of the full-scale invasion, HRS was focused on stabilizing the healthcare system and ensuring the continuity of care. In 2022, we modified our scope of work to include a focus on the recovery of the health care system, and we're doing this in 2 major ways. First, at the national level with the Recovery Project Office and implementing partner coordination, and secondly, at the community level with our grants programs. At the national level, HRS has established the Recovery Project Office, also known as the RPO, to liaise between the government of Ukraine and international donors. The office has been very successful in identifying which healthcare facilities have gaps in equipment or supplies, and then coordinating the delivery of those supplies to those facilities. In total, it has supported over 2,795 healthcare facilities and initiated over 2,000 restoration projects across 873 facilities, and delivered over 10,000 pieces of equipment that are critical, such as generators, Starlink units, and alternative heating sources. HRS also helps implementing partners to coordinate with each other by collecting data from IPs that are working in the country and identifying where they're working and which facilities they're working in. And then taking all of this data and then visualizing that on a dashboard. The dashboard helps implementing partners to understand where to avoid duplication, and second, where to coordinate with other IPs to achieve a more complementary objectives. And I know we have also enjoyed the benefits from that when we're sitting down to design training programs, for example, and being able to identify specifically where others are training to avoid that, not just that duplication, but also not crossing over on top of each other and perhaps stumbling over each other's feet in implementation. At the community level, HRS has two main grants. The one focused on expanding access to quality services, and the second is focused on helping healthcare facilities repair non-structural damages from the war. The first grant initiative is our Reconnecting People to Care program, which of course is also known as RPC. And the aim of the grant is to strengthen the capacity of local health systems and restore essential services by expanding access to quality services and targeting vulnerable groups. So under this RPC program, we have two specific objectives that guide its activities. The first is to expand access to quality services. The program seeks to achieve this objective by increasing the number of primary healthcare centers supported under the HRS grant program. The aim is to enhance the capacity of healthcare facilities in targeted hormadas to provide readily accessible and essential healthcare. These services are also, we want to ensure that they're readily accessible to the populations. Our second is to target vulnerable groups. A core focus on increasing access to information, medical services, social support, and psychological services for vulnerable groups. This includes populations facing unique healthcare challenges. The grantees that are under this grant operate within specific oblasts of Chernihiv, Kharkiv, Dnipro, and Zaporizhzhia, and they are expected to design activities that are both community-centric and tailored to the needs of the local community. RPC grant program in total aims to cover 134 hormadas in these 4 oblasts. Many of the representatives from these hormadas are present here today at the conference. The second grant initiative that has been distributed to 8 healthcare facilities to help them repair war-related damages and restore services. We plan to issue an additional 7 grants, which will enable over 2 million patients access to restored health services. Additionally to that, HRS has also launched a separate big grant program in Chernihiv, Sumy, Dnipro oblasts on strengthening the capacity of PHC facilities to deliver palliative care, something which the minister was referring earlier this morning. Under this grant, HRS is supporting 40 healthcare facilities in order to expand and improve the range of palliative care services provided at the PHC level and enhance their coordination function in their hormadas. Oksana?
Mr. Elkins, я ще дам.
Mr. Elkins, I will give you 1 more minute, Mr. Elkins, because I was going to ask you another question. We would like to know more about multidisciplinary approach. Can you please use this 1 minute to explain on it?
Thank you for the extra time and the question. I think first, HRS strongly supports a multidisciplinary approach because the program itself is a multidisciplinary project. Our team is composed of lawyers, doctors, health finance experts, health workforce experts, and IT specialists. And this diverse team collaborates to deliver holistic activities that address the multifactorial nature of Ukraine's healthcare systems. So we know that multidisciplinary approaches can be effective in addressing complex problems. And when the full-scale war started and there was a large influx of displaced Ukrainians, we created an activity that brought together multidisciplinary teams of doctors, nurses, psychologists, and social workers. Many of the people that were displaced had experienced mental trauma, and so they needed a psychologist. Many had chronic diseases, and so they needed a doctor and nurse. And because they were displaced, they needed a social worker to help them integrate into their temporary homes. These multidisciplinary teams were able to provide holistic treatment for over 2,000 displaced people across 6 oblasts in Western Ukraine. This is an essential part. The multidisciplinary approach is an essential part of our Reconnecting People to Care program. 25 Hormadas across the country will start implementation of the package of interventions for a multidisciplinary approach, which has been designed by HRS and implemented in previous years. Together, representatives from 25 Hormadas will have an opportunity to take part in a more practical part of the conference tomorrow, particularly about implementation of this multidisciplinary approach in their Hormadas. Thank you.
Дякую. І наступне питання у мене до пані Альони Герасимової.
Thank you. And next question is to Alyona Gerasimova. Alyona, maybe I should ask 2 questions at a time. If you're ready, I am ready. You can see, I have my notebook with me. Probably I should ask you 2 questions, and then you have 6 minutes. 6 minutes plus 1, like David has. Yes, if you like it, if you need it. Okay.
So the first question, implementing the models and interventions on restoring the access to high-quality services at the level of communities. Second, regarding the multidisciplinary approach. So this is actually the key thing that I'd like to trace, tracing the experience of coordinated USAID projects, okay? Just to grab some of your expertise. Okay, thank you so much from the title of the project, Building Resilient Public Health System in Ukraine. Everything we do through the prism of public health. Everything like prevention, strengthening health, maintaining the proper level of health. So, of course, longevity issues. And when we started working at the level of communities, we basically, I heard many of these things today. I came from my business trip and I joined later, but I heard of this human-centered approach. For us, it was really important when we went to communities to listen to people. What are their expectations? What are their hopes? What are the problems and so on? And we started with the following. We had a survey for the needs identification locally, questionnaires, interviews, in-depth interviews, focus group discussions, 16 communities we had, and we asked people, what is a healthy community? Okay, tell us. Almost 60% said healthy community is access of medical services. Another 40% said clean environment. 33% said comfortable place to raise kids. 60% of respondents consider their communities healthy, but when we ask them about their personal health, do they consider themselves healthy? Only 40% said yes. So we asked residents what are the most important problems in the communities from the standpoint of healthcare, and 60% said cardiovascular diseases, they mentioned that, hypertension, 42% oncology, some communities, not all, mentioned the diabetes issue. Again, what is a concern? Access to services, what we discussed today. If we take the rural areas, transportation, lack of transportation, of course, and for people it's really hard. Elderly people in rural areas, for them it's hard to use all these super fashionable, trendy digital things. This is a challenge for them, And we spoke of the local healthcare stations and spots. These are closed, that they're not comfortably placed, and actually the price of treatment. And lack of awareness-raising campaigns mentioned, and also lack of prevention measures. Residents mentioned it. We talked to decision makers. They had complaints, more complaints on infrastructure, road quality, transport connection as a problem. Spoke of environmental issues, problems of addictions and domestic violence as well. So much was mentioned about the leisure and sport and the local let's say, convenience, social convenience, and lack of basic services. We analyzed NHS data. 95% of population in these 16 communities where we actually launched the survey, they have declarations signed with their family doctors. The load on a doctor, 1,300 and 1,500. 63% of respondents know about the accessible medicines program, but only 19% actually use it. So we also checked that 60% at least once per year went to medical facility, but only 20% used the healthcare service. The majority wanted to ask for certificates and so on. Based on that information, we talked to our communities, we engaged them in the co-creation project, and we came with a concept, Healthy Community, and something that we implement today, Healthy Community, as a pilot only in 5 communities. 4-component process, integrated primary level, as we call it, where we have extended list of services provided by doctors, and the strengthened role of nurse. Second component is obligatory component, the mental health issues, psychosocial support, It's an obligatory part of the package of services, and of course, obligatory awareness raising and preventive program, because again, we have this cascade of non-infectious diseases, and we really want, of course, for people to stay healthy and to know what are the risk factors, to have some healthy behavior and lifestyle. But for them to have access to screening programs, to timely detection and getting treatment if they need, just like with HIV/AIDS, but for cardiovascular diseases as well, and for the oncology, and for diabetes, the cascade is the same. So we launched again the grant program where we engage NGOs and CSOs as active partners in public health sector for them to help us to prevent these losses in the cascade of service provision. And again, as we all live in the wartime context and we have these constant challenges and threats in terms of public health as well, our 4th component is that community has to create a plan, a crisis response plan or emergency plan. So we are doing everything that everybody else is doing, basically. Training, team preparing, multidisciplinary. These are truly are, but it's not just social service and healthcare. We engage education, we engage NGOs and CSOs, we engage religious even organization, and we create this collaboration to strengthen the public health systems. So they actually all operate in collaboration as teams at the level of each specific community, and they merge. I can give you the names of communities. Zhytomyrska region, Ovrutska community. We have our colleagues there. It's so nice to work in Ovrutska community. Vinnytsia region, Жмеренка, Могилів-Подільський communities, Ivano-Frankivsk region, this is Kosiv, and Kyiv region, Fastiv community. Thank you. And my additional question, just to clarify for another minute. Okay, tell me please, do you want to scale up? Do you plan to do it for other communities? Yes. Actually, we have conversations with our donor, USAID, that we only start the activity. This is the very first step, and of course, we will expand the geography. Thank you so much. Okay, I took notes out of your speech. Yes, I took something useful on how thorough your study is when it comes to needs of population and the strategic planning. Because I can see that you're designing your plans on the foundation of the data that you get and the analytics. Thank you, and the round of applause to you. Please don't forget to applaud. Okay, remind me of saying this to you. Okay, and then we have Alina Tereshchenko with us. Okay, Miss Alina, I just want to ask you about cooperation between experts and organizations from various sectors. Okay, this is the key thing that we study at this conference. It's in our focus. Okay, for example, social and healthcare. Okay, we touched upon this already in the first panel, but it's interesting to know what is your experience like, or how various representatives of various level of healthcare system work. Specialized and primary, for example, how they interact. Thank you so much for this question. Honestly, our project, strengthening rehabilitation services in health system, well, this is the 5th year of project implementation, and honestly, if I try to draw a sort of conclusion here, like thick red line to be drawn in the context of communication and cooperation, I would love to single out education. Education for rehab experts and those approaches which we applied under the project, and the approaches that we really consider great to be scaled up. The importance of clinical component and clinical training, basically for those future specialists and professionals who are now still students and they still acquire their knowledge as physical therapists, they study as ergotherapists, yes, quite, we can say this is something new for our country, especially ergotherapists, for Ukraine. So basically the cooperation of higher educational establishment with healthcare facility in the process of training provided for professionals, those who will be able to work like in the field, later, those who will see and touch the actual patients, let's say, and who will not be afraid of doing that, but just getting feedback from their supervisors, who will be motivated enough to actually continue developing professionally in the rehab sector. And in this specific area, in the project, we had also cooperation established between 5 educational establishments, higher educational establishments, and 5 healthcare facilities. Cooperation like university and HCF, yes, like in this cluster for joint training provided to specialists. The results, I can say that we will, in half a year, we'll try to finalize these results and accumulate them. But this is the approach that is based on the best practices. We've been shaping it for years, and this approach is operating in many countries which are Ukrainian partners. And this is the approach that actually at national level was approved with amendments to educational standard for physical therapists, ergotherapists. And in fact, the approach that we would love to develop with our communities, this cooperation in rehab specialist training. Okay, apart from the idea that cooperation in educational sector, well, it's immensely important because, again, education, of course, you added one more sector that is really required for synergy. Yeah. If we train the specialist will help person to recover. Okay, if we speak about the rehab people, right? But if you talk about other sectors and services like rehab services, we realize that specialist is just one of the components. I think one of the most important is the core, but just one of, okay? Let's not forget about, of course, the technical, let's say, support and the funding. Conditions for these people to operate should be decent. They should meet the level of their professionalism, and for the client, for patient, it's about decent conditions of work. That's why responding to requests of people, the response given by community, response given by rehab experts and rehab unit managers who faced in 2022 the following situation. Well, they observed that there was not enough of HCFs able to provide this highly specialized rehab support. And basically people with such injuries, like, for example, spinal injuries, nowhere to be transferred. Because, in fact, this type of patients, well, rehab facilities are not ready to provide this type of support to these patients. Okay, if you take cooperation, primary level social workers, specialized support. Okay.
Зусилля проекту
The efforts of the project were mostly directed at the specialized care level. If we speak about healthcare, if we talk about primary level, the PHC, this is in our scaling up plan. As a project, we realize that primary component itself is a basic one. It's an entrance, let's say, or an entry point. And primary level specialists, these are people who could have been able to refer to rehab, patients rehab. Identifying those red flags when it comes to person's behavior, one who is subject to rehab. What the ministers were saying, do not lose the person. Yeah, but carpe diem, seize the moment, seize the person, and tie this person to another level. Well, the rehab care must be provided like specialized level. And of course, the community, for the community, I would tell that the experience of peer-to-peer experience, of this concept, it worked really interestingly. The peer-to-peer approach that we used, a person who was injured, who has the trauma earlier, the one who learned how to live with it, who's an active member of society, but this person specifically understands all the problems that people with fresh injuries have, okay? Speaking of scaling up, all right, you mentioned the scale-up plan. Okay, tell us. Yeah, okay. As I mentioned already, that the approach of education plus healthcare cooperation, we want to scale up the project within the next 5 years, engaging other communities, of course, engaging other HCFs, and higher educational establishments. Apart from this, of course, working with PHC level when it comes to rehab care and more active engagement to the primary level of rehab care. So I would stop at these two, all right? But definitely we will scale it up, and we will be really pleased to expand again the geography, to get more regions to cooperate, of course. Thank you so much, Miss Alina. The key statements from the speech. Okay, education and training. If you start instantly working, cooperating with those people who are trained now, it will be easier to make them aware of what integrated cooperation is with other sectors. All right, so I would love Oleksandr Komarida to speak. Okay, I have a question to you now. I would love to know more about your organization's expertise in restoring the access to healthcare. In particular, how the implementation of your initiatives impacted by this human-centered approach. Again, human-centered approach and directing yourself at people. Okay, thank you for the question. Good afternoon. So our project, Community Action for HIV Control, in the framework of restoring access to healthcare in communities, of course, firstly, we direct ourselves to the needs of the communities. But when we do talk about the needs of communities, we have to clearly distinguish something they wish to get and something they can get, actually, the actual needs. What we faced when we worked with communities, now we cover 5 regions already in 12 communities. We've expanded 2 weeks ago also to Sumy and Kirovohrad regions. Before that, we only have Kyiv, Chernihiv, Zhytomyr regions. And respectively 2 weeks ago, the services in these communities and regions were launched. When those people who live in distant settlements, remote settlements, we speak of these primarily, when you ask them what you need, they need everything. Because if we compare even with small towns, I'm not even mentioning big cities, they have very, very limited access to healthcare and other services. Yes, with a microphone. Thank you. And they need everything. Of course, any project, regardless of the funding scope and the capacity, including human capital, there isn't any single project that can cover all. So we need to clearly identify what are the needs, what can we cover primarily, initially, which of these needs are urgent, basic. So for ourselves, and we used various results of various studies, talked to communities directly. So we get support from NGOs as well because we work via them as well. We identified the essential needs, the priority needs, and we tried to satisfy these as fast as we could. For priorities, we identified mobile healthcare teams, multidisciplinary mobile pharmacies, psychological support spaces, and patient transporting service. Currently, only psychological spaces are at the stage of launch, actually, and these will start operating in June. All other services are fully operational. Okay, again, very interesting to know the research. How do you carry it out in the regions where you actually are present first? Well, we start talking to local authorities. The level of regional military administration, then Department of Healthcare, then directly local sub-governance bodies in the community, the head of community, village heads, village leaders, and we talk to them. Instantly, everybody's engaged in those processes, NGOs, I mean, all NGOs, which coordinate that type of activity, and then together with them, we identify what we need. And of course, we learn as we work, we adapt. Of course, if we speak about mobile healthcare teams, it comprises the PhD doctor, a nurse, for example, social worker, and a psychologist. But when this mobile team goes to work elsewhere, they already have certain data on settlements, and when next time they return to the same settlement, and we have the system that it's not just single visit, okay? Then the mobile team is engaged, a specialist is engaging the team, like, for example, cardiologist or maybe dermatologist, I don't know. So a professional. It depends on the need. But it's not just about sending a doctor there. We also have to make sure that we have all necessary equipment on board. First of all, for the doctor to make sure to perform the screenings and to train the doctor to use that equipment. So you instantly create the interdisciplinary team, in these mobile teams. We have two levels, multidisciplinarity, if we talk about the project. First level is the team is definitely multidisciplinary. They provide all necessary services. Social worker instantly refers the person and screens one, because we have screenings designed for these typical non-infectious diseases, like, for example, the cardiovascular diseases, then also the hearing loss. We focus on that. And psychosocial screening we have designed for when it comes to GBV, because this is very relevant now, and they try to provide all the package of services to people, all necessary support. Second level, if the mobile team goes, it followed by the mobile pharmacy. They go to the same settlement, and people can get the medicines they need with a prescription provided by the team, including the medicines under the reimbursement program. And when there is a need to provide psychological assistance and care, there is a high demand, and people are referred to these psychological spaces where the online service provider, there is an administrator that can bring person to a safe place, confidentially put next to computer to get services. When mobile team identifies people who must be transported to a healthcare facility, for example, in the center of community, or we, of course, provide this service because a planned transportation. Colleagues mentioned the transportation issue, logistic issue. Yes, it's quite an acute thing, especially when it comes to rural areas, remote areas. Okay, another thing that you add to the synergy. Okay, would you tell us something? Do you actually plan to scale up these models to other regions? Yeah, sure, we do. We do plan to have this. We've just added 2 new regions and 4 communities. First teams came there in January 2024, 3 regions. Now it's the end of May, start of June. We launched 2 more regions, and we communicate to donors as well to expand the number of communities. But still, we think maybe not expanding the number of communities, but maybe expansion and sustainable provision of some services, because one of our key goals is the sustainability of service provision. So not to lose patience between the links, after the project is over, maybe not all, but basic services, for these to be operational at the level of community, for the community to have enough financial resource, including the sustainability of service to be guaranteed. I think that all colleagues, these services are in high demand, and people are not so pushed to get the service. People are willing, they're interested, because they get a service and they also get high quality of the service, all right? And it actually improves the quality of life and health of these people. Thank you so much.
Thanks for sharing your experience. I would like to ask the would-be speakers, please hold mic closer to your lips. And the point is that it is important for the online viewers to hear, and it is important for the translators to hear as well as again. Now I would like to give floor to Vitaliia Trokhymets. And I would like to continue. Please share your experience of multidisciplinary teams. Thank you. Good afternoon, dear colleagues. Our project and overall activities are a bit different from what we've heard as part of this panel session. As part of the major HealthLink project, since April 2023, we have been implementing the recovery component. Our target region is Dnipropetrovsk Oblast, 2 rayons, and 14 PHC facilities. It is important to say a few words about the prerequisites. So the coverage is 400,000 people, 50,000 IDPs, which also affects the activities. These are very different healthcare facilities. In many cases, they are small facilities with less than 10,000 registered patients. So it affects the activities and the communication as well. In many cases, these facilities are applied just for one PHC package, but at the same time, there are facilities like Kamyanske PHC facility number 3, which is huge, or Pavlograd PHC center. And as for the support, recovery support provided, well, we provided technical assistance in the shape of training for different teams, the nurses, for doctors, and for managers. After the training, after the needs assessment of vulnerable populations, we have procured some equipment. We procured vehicles. Because, of course, the doctors and the nurses sometimes have to walk dozens of kilometers to reach their patients. So we procured not only cars, but also bicycles and scooters that could be used by health staff. Speaking about vulnerable populations, we have procured a lot of baby nutrition and also diapers and other supplies. And we also ran 2 large communication campaigns because we have large numbers of IDPs. And together with the local authorities, together with healthcare facilities, also veteran support centers, we disseminated information on services that can be provided to relocated and resettled people. In addition to that, we ran a communication campaign on prevention of certain NCDs. with the support from stakeholders I already mentioned. And in addition to that, following the request of the MOH, we have developed communication training course on the NHSU Academy platform. This is a communication course for this is the course for the communication with the people affected by war. And also we launched a pilot project under Bohumoltsi National Medical University and with support from UCU Business School. And then the design was shared with the faculty of the university so that they could scale up it in other medical universities in other regions. So we believe this is a sustainable activity and it could continue after the project is over, and the project is over in 3 weeks. So you just summarizing your accomplishments and your deliverables. And my second question is, I heard a couple of messages as for the collaboration with local authorities. So this is another interesting experience. We haven't mentioned it yet. Can you please focus on the collaboration with local authorities? And in which areas? And with what organizations could you please name a few examples of successful collaborations? I don't know how it would sound, but I love this project. This is my favorite project. I adore it. And next week I will be able to visit all 14 healthcare facilities and talk to them. And to be honest, Kamyenske and Pavlograd rayons, they are pretty hard to move. And I believe we can talk about trust here, because they didn't really believe us that we could quickly procure and deliver equipment. And only when they received it, they said, wow, thank you so much. Same with the authorities. You invite them to attend some trainings, you explain the importance of these events, and some part of them just attended the events, and finally they are very surprised. And like those two rayons are expected to have communication and collaboration, but there was a feeling that some facilities and some people have seen one another for the first time. And that's the synergy that you can see during the trainings. They build their plans. They try to understand how they can cooperate. That helps and that inspires. So your experience is positive. Finally, yes, it is. Thank you. And now I would like to give floor to Ms. Gunta Dravnice. You said that you would understand it in Ukrainian, right? So I can ask you a question in Ukrainian. So please share your recovery models under your project. What is the role of these models in the successful implementation? And where is the role of the multidisciplinary approach?
I will talk in English. Apologies, you don't want to hear my Ukrainian. Our project initially support TB control, support tuberculosis control efforts in Ukraine was a simple tuberculosis project focused on tuberculosis. That's why we have nicknamed tuberculosis project. But we are far more beyond tuberculosis activities, and today I will not talk about access to TB screening, etc. That's also a major part of the project. But with the war, our portfolio was expanded to enable access to healthcare services, like for many of my colleagues here. And we were thinking within our team, what could we do? How could we make sure that there is access to simple services? Not everything is so advanced and requires advanced approach. So we decided to extend or decentralize care to Hromada level. And what we did, we supported Hromadas to establish health access points. What is health access point? It can be in any place in the village, in remote areas, where people are coming quite frequently. It could be club, it could be library. And so we established 171 health access points in 10 gromadas. You can see on the map, I will not name each gromada. If you need some more details, please contact us and we will provide some more details. What we did, we selected those points, we discussed with gromadas, we selected those potential health access points. We explored what is needed to provide access to most common non-communicable diseases like diabetes, hypertension, some types of cancer, and some other diseases. So after assessment, we procured project-supported procurement of basic equipment, weights, tonometers, glycometers, nothing complicated, very simple tools. We engaged several family doctors who helped us to provide training on how to use those tools, how to talk with patients, with your neighbors, how to promote screening, because our main purpose was to ensure early diagnosis of most common diseases and establish referral system connection with primary healthcare. So those points, to our surprise, we were not sure about how will it work. It works, and as you can see that more than 10,000 screenings are conducted so far, and many people, several thousands, are identified with some issues. It could be early hypertension, several patients with early stages of cancer. And since last year, we added one more component, mental health, because we expanded our portfolio also to mental health. So we included simple mental health screening tools in those health access points. And you can see that more than 7,000 people were screened and 149 were identified with issues requiring additional attention. So this is one example, and talking about next steps. Of course, after referral to primary healthcare or maybe to secondary level, people will be prescribed treatment. They will have to continue treatment. So we want to make sure that they are adherent to treatment, that they use this treatment, that there is effect actually. It's not just that tablets are prescribed. So that's our next step. And for the next project year, we are entering into the last project year from October 2024. We would like to expand this to some other gromadas. I cannot say how many, in which exactly, but that's our plan.
Пані Гунто, і ще до вас одне.
Yes, Ms. Gunta, and one more question to you. In your opinion, the models that you presented, how relevant they are to scale up in other regions and to embrace communities located closer to the front line?
I think this model is also useful or applicable in regions which are close to the front line, especially because there is acute shortage of medical staff. So that could be some solution, some bridging for access to health services. So we are open for suggestions, for requests from regions, because it's essential that there is political will at Hromada level, that Oblast or Hromada administration is willing to collaborate. That's a key point.
Я почула дуже цікаву фразу. Ми чекаємо.
I heard a very interesting phrase, like we're waiting for the request. How can this request be made?
Our contacts, or you have our contacts. Participants can send their ideas, their requests, and we will consider, because the project is working throughout the country. We work in all government-controlled territories. We didn't decide yet to which gromadas we will expand, so we are open for suggestions. I hope I didn't promote too much, but thanks.
Та, тому я для
Yes. So for the representative of communities, I will give the name of this organization and project again. So USAID-funded support TB control efforts in Ukraine activity. The project is implemented by PATH International. I think you can Google it and also find contact details and approach the project. Thank you so much. So your speech was particularly helpful. And next, I would like to give floor to your colleague, Ms. Gunta. Thank you. I forgot to ask for applause, but the participants remembered to greet you. So, and our next participants, Tetiana Gaborets. Tetiana, and again, same question to you. Is there any opportunity for the conference participants who represent communities to collaborate with you? Thank you. Good afternoon. Reach 95 project. This is a project that started last year. It started on the 1st of August, so we are in the first project year. And the main purpose of this project, basically the title is Re-Envisioning Excellence and Accessibility in Clinic-Based HIV Services until 2030. So there are several objectives under the project, and one of them is related to the scaling up of access to HIV testing in healthcare facilities of all levels of care. And a few words about that. The project embraces nearly 300 healthcare facilities of second specialized and primary healthcare, and PHC facilities constitute 99 facilities, which is quite a few. And PHC facilities is one of the priorities for collaboration while providing access to HIV testing services under Objective 1. But in addition to Objective 1, I have to say that Objective 2 is about scaling up human-centered approaches to the provision of quality HIV services and to reduce this stigma and discrimination by health professionals. I mean, HIV-related stigma and discrimination, which would improve access to quality services. We believe that if healthcare facilities provide quality services, that would be, HIV testing services that would be linked to treatment and prevention services, and the services are available and health professionals will provide them without stigma and discrimination, the population will seek the services. Therefore, people living with HIV will be diagnosed in a timely manner and the treatment will be prescribed in a timely manner. So that's what we are doing under Objective 2. Under Objective 3, we work with communities and primary healthcare, because it will promote decentralization and the delivery of the complete HIV services at the PHC facilities. It means collaboration with PHC centers, and right now we work with the Oblast health departments and CPH, and we selected 18 PHC centers which are ready to be contracted by the NHSU, and they apply for the complete HIV package, not just testing, but also confirmation, treatment, and support services at the PHC level. And when they are contracted by the NHSU, then the services will be provided in these facilities, and the facilities will be able to receive payment for their services. So the project trains facilities and staff to be able to provide such services. We are working with 18 PHC centers in 3 oblasts. A few words about the Chernihiv Oblast, because when we visited the oblast last year to do the assessment there. They were pretty proactive, and they said they wouldn't wait for the next year because, like I said, these facilities will apply for the packages next year. They said that they were ready to provide the services. Please train our experts. So we selected 3 facilities. We trained specialists from these facilities, and they were contracted by the NHSU, and they have been provided the complete HIV services since January. And we have the first results, because people living with HIV, they are identified and at early stages, and they are linked to care at the PHC level. A separate intervention that I would like to mention, and this is due to our partner project, our Stop TB project. As you can see, Gunta just said that they were working in the communities. We planned, and together with the Stop TB project, we decided to work at the community level as well, and also to add HIV testing services, like self-testing services, to the screening services. To add them to the services that are provided at screening points. These small healthcare units, they are created not in healthcare facilities. And so the project will procure and provide self-testing kits, self-screening tests in this communities, and we start from one community in the Chernihiv Oblast, and then we plan to scale up in other communities. So people living in these communities will have access to HIV self-testing with support upon their consent or without the support. So the staff member of the screening point will provide support services, help with the self-testing, and help to interpret the results. Of course, upon consent of the client. If an individual doesn't want any support, they could be provided with the test and do the self-testing at home. A few words about the multidisciplinary approach. So I would like to say that in each region, we have a multidisciplinary team. We have a regional coordinator, we have an M&E coordinator, and social work coordinator. And the social work coordinator's task is to support and to link people living with HIV to NGOs that provide support for people living with HIV using state funds. So this is another initiative as part of our project. And we just started. We have many plans, many innovations that we would like to try. In particular, we would like to build multidisciplinary teams in PHC facilities. And the teams would include a doctor, a nurse, and social worker to provide comprehensive and integrated services. Thank you so much.
Thank you. Honestly, the final speech, and you just, this is a big, thick red line under all these key statements that we give, and something that really want to get as experience. Okay, we have a chance now to ask, get a question from the audience, if you want to ask our speakers something. But you need to have a microphone. That's really obligatory. So, who is your target? Or it's for everyone. Introduce yourself, please. Hello. I'm here. My name is Ivan Prelipko. I'm the expert of healthcare platform of Ukrainian Association of Communities, healthcare consultant and expert, forum transformation. Yeah, that's a very, very long title. Loads of credentials, but I'll have 2 questions and 1 comment and offer. Because, I have many roles. Okay, today I've heard many times about integration, cooperation, dialogue, expansion, communication, vertical. interaction, maybe something else I heard. So, as a representative of an association that actually unites 850 communities in Ukraine, 700 with less than 25,000 of people, rural area, more complicated access to healthcare. So I offer cooperation with us. We have a structure. We have regional affiliates. Okay, we have specialized network in each of sectors: social support, healthcare, education, and so on. All your calls and all your statements and questions. This whole thing may be solved, or we can extend it with the cooperation. Yeah, so far I haven't seen that kind of cooperation, and my presence is quite a random thing to happen. So I invite you to cooperate. Second thing is purely an expert issue. So each of your projects or initiatives supported by USAID usually runs the assessment initially when you start the project on the needs, needs of communities in specific sectors or the healthcare needs. Do you have a methodology, a single methodology for that assessment to take place, a tool, or how exactly is that happening in each of your projects? Do you actually negotiate and harmonize that? Can we compare the results of assessment between communities? Because each of your project is covering so many communities, and it may be better not to waste resources, but methodologically somehow to unify that, to have a unified approach, a sort of. Or maybe this is already happening because the donor is the same. Thank you. Okay, your question goes to who wants to, if you negotiate and if you harmonize the assessment. I can actually, I can answer from the pact. Give an answer because we have two projects of ours here. We do coordinate that, of course, internally, and we have joint assessment, and we jointly design the tools, SOPs, and so on. We strengthen each other, and we spread each other's expertise. I don't know if it's a unique situation. Maybe we're just lucky that one organization is implementing two projects, but definitely you have a very, very good comment. To avoid duplication, of course, and not to waste money. Yeah, we coordinate. We at least try to do that. It seems to me that we do it pretty well. So, Alexander, thank you. Yeah, I just want to add, definitely, when we plan any activity, we negotiate, we delegate the roles and responsibilities to avoid duplication. And we also exchange materials from our experts in particular, use it in our activity, and it helps us a lot to expand the service coverage. I have the answer for association. We are open for cooperation, but maybe you need to talk to the association members, actually, to bring it to us that there is such an association that can help us, because in 12 communities, 5 NGOs who are partners, nobody even mentioned about association like yours, and we'll be happy to do that, of course. Tatiana wanted to say something. Okay, dear participants. If you came to a table with all these books, leaflets, and guidelines, there was also the results of the basic assessment of facilities' readiness to provide services on HIV. And initially, when the project started, together with PHC, with the departments of healthcare, we launched that type of assessment, online assessment. A single link was given, depersonified data we had on whether the facilities are ready to provide these services. For example, we had the question, does the facility need training to be provided to specialists on HIV services? Does the facility provide HIV testing service with rapid tests? Are there enough of these tests in the facility? Just example of questions. It wasn't one single unified methodology. It was a project methodology approved by partners. As a result, after this assessment, we definitely confirmed the promptness of our project, and that the need of facilities to train their professionals, high percent of We got so many answers to the question that yes, almost every healthcare facility, and we had approximately 900 of these, which were respondents. And yes, they are in need of training. So, based on the results, I just want to tell you that yes, we already started this activity, and we provide training not only to doctors and nurses as well. We realized that you have to train not only doctors for them to know who should be offered to get those services, but also nurses as well, to know how properly to test people. Okay, so before the project even was implemented, before we started, we did that. The other approach that we want to start in 2025, this will be in tight cooperation with CDCs on selection of HCFs, for example, those where there is a need to decentralize services on full HIV package. Now we work with 18. Next year we'll take 18 more. These will be completely different regions, and we will cooperate there, and they will also have certain assessment taking place on the need in this specific facility to disseminate decentralization there. And David Elkins.
Which was, is there a common survey? I think you can draw the conclusion that no, there's not. Each partner has developed their own mostly based upon their circumstances and what their deliverables are. Would it be useful to have a common base survey? Of course there would be, because it gives you comparability across the oblasts, across armadas, and that could then be useful for new organizations as well. So I would agree that a common base survey when entering into communities could be very helpful. Part of that one baby step with this is with the implementing partners dashboard, which is collecting common data across all of the activities. A common survey would also be very helpful, not just in terms of building up that database, but in supporting others who are coming in and identifying where the gaps are. So I think that would be a very good idea. Coming back to your organization, I think probably each one of us is still learning about organizations that are present in Ukraine. There are many, many organizations that are out there. There are many new ones, both because of the funding, because of the war. There's a lot of drive to support Ukraine in any way possible. So I think it kind of, I would push this back to you to say you need to try to be more aggressive in terms of approaching the projects, because all of us are running at 100 miles per hour, and we're both keen to embrace new organizations, but we may miss them as well. So.
Дякую. Будь ласка, наступне запитання.
Okay, thank you. Next question. I saw a hand in the left sector on communication. I have to answer, if I may. If you want to reflect upon that, okay, just a couple of seconds. 20 seconds I give you. Okay, interacting with organizations. Definitely, you know very well in your projects what is the capacity, competence of local authorities in healthcare and their, let's say, competence. When you interact with them, please do that via the association as well, with our help. We will have this Ukraine-Swiss project event for them on 25th of June, and we gather all the committees. For each project, we can do that, yes. Okay, and we're coming to next question, I guess. Thank you for remark. Thank you for the question. Yeah, you had 4 answers from 4 speakers, and I do think that this is a new constructive aspect that we managed to reveal. Who are you? Tell us and ask your question. Hello. Pokrovska Village Council, Nikopol District, Dnipropetrovsk region. So head of healthcare department and social protection as well. And your name is Inna Shostak. My question goes to you. So at the level of community, representatives of 25 communities were selected. Those with over 25,000 of population selected. In our community, we have less than 10,000 people, but we also have 8,000 IDPs. Sorry. What to do with those communities? We also want to train. Okay, we also want to use that approach. Like, it's a question to all of you. Vitaliia wants to answer, I guess. I'll be the first one because 100% live as a grantee. We will implement RPC programs in Dnipropetrovsk region. I'm so happy to see you here. Honestly, one of the conditions to take part in certain interventions, yes, up to 20,000 of declarations signed, there was a condition. And what we communicated, what our partners communicated, it's important to have the capacity in the facility or in the community at the level of, with the number of medical staff or other staff to take part, because still it's a big process, a complicated process, a lot of time that should be spent. We understand that these are the territories that there may be like the deficit of personnel, a substantial one now, and they need to provide services to people. The medical staff should go to training. They will be taken out of that process. Then they will report, and like, it's a hard process. And we took this mostly as something to base the concept on. We are advocating this. If the community, the facility, want to participate so strongly in an intervention, we will try to make this happen, because, as I say, from my expertise, not always you can get energy and wish to change and to do something, and also to understand why these changes are important. I can tell you that we'll do everything that is possible to make your wish come true. Thank you. Do we still have questions? Please, just one more. And first row, who you are, raise your hand, because, yeah. Hello, my question is, I guess it's more to David. You said that projects is about expanding the services and repairing in future. Do you plan some new projects? Because we have communities where there's nothing to repair anymore, like rebuilding new hospitals. This is really interesting, like new projects.
First, we are in our final year of HRS. And so we probably will not be taking on new activities given our timeline and given our remaining budget. And so, but there is a new program that will be coming in, I believe, October 1st, which will be continuing health care reform and will probably be readily embracing new activities as well. So I think from our side, I think the idea of taking on new activities at this time, probably not. But the new program is, the new USAID supported program is starting October 1st. It's going to be a 5-year program, and I think it's going to be very exciting in terms of its support for changing healthcare in Ukraine.
Так, дякую за відповідь, дякую.
Thank you for the answer, and thank you for, yeah, we have almost 9 minutes, and I offer us to have some intense conclusion to be introduced. Okay. This time I will not give you extra time, extra minute, just one, just stick to timing, just 1 minute, very, very concisely, and I would bring these 2 statements. Maybe some insights will pop up or reflections on what we managed to generate today. Like, what are the next steps that you see in the process of restoring, or maybe share some of your insights? Like, what should be highlighted of what we mentioned today for this to stay as an achievement, you know? Elkins, maybe you, Mr. Elkins, maybe you can start.
Present their programs and the different modalities that they have in reaching out to communities. I think that discussion of course, tomorrow that discussion is going to be quite extensive from the Hormata level. I think we still have a lot of work to do ourselves in terms of being more open in terms of the different strategies that we have in embracing communities and really looking at some of those lessons learned. Not everything works. And I think that bringing together the leadership of the programs on a more regular basis to share some of those successes and experiences is only going to strengthen Ukraine more and be more efficient in the way funding is utilized.
From our side, I can say that definitely our next steps are to expand geographically and also to add additional elements, like I mentioned, mental health, and like Tatiana mentioned about HIV testing at Hromada level. We also, what we heard today during the conference, we could collaborate with some existing activities. For example, the Dostupni Liki, it's logical step after testing for most common diseases, and also I think some of the speakers mentioned engagement of nurses. Nurses could do much more, so we will work on that. Thank you.
Тетяно.
Okay, provision of services, human, people-centered services to be provided and to approach these to people. This will be, of course, this will give us success because people will use the services, and these services will promote the early detection or early diagnostics of various diseases, infectious, non-infectious, and this will promote the early treatment, and of course we will save lives and save health. If we implement services at the level of communities at primary level, in those centers where people face the providers for the first time, okay, when they have the first contact, and this is a comprehensive and integrated package of services, not just screening, not just diagnostics of one pathology, of one disease, but if we take human being as, as a system and screen, then it's going to be success. Alina. I would stress, I would focus on 3 components that actually we use and we plan to use in our rehab strengthening project. So first thing is request from communities, realistic request, all right? But their vision, their needs, their wishes. Okay. Second is cooperation, tight cooperation that many spoke of at the first panel, because just the discussion, it's just the discussion that gives result. Discussions give spark to truth to emerge, let's call it like that. And piloting. It doesn't matter how fast we have to move now, but it's still wartime, and somewhere we can do it faster. But piloting is itself a component that allows to forecast better and to guarantee some results at least. Okay, Oleksandr. Thank you so much. Honestly, it's so hard to give reflections after my colleagues. Okay, tell that you agree. Okay, I agree, of course, but considering the requests and considering the discussion dynamics, it's important also to train personnel locally. Starting from the medical personnel, and the managers in healthcare system. Because in the projects, we have so many trainings held for ourselves as well, and we have very good presentations and graphs, and we have very nice talks to everyone, but sometimes what we lack, the link a bridge that would tie us and projects and NGOs to patients. So for future, this will be one of the biggest challenges in Ukraine, considering the situation with the staff potential. Negative trends are there now because we have the Russian aggression. Vitaliia. I responded emotionally to this somehow, and my answer will be emotional as well. Thanks to USAID and thanks to their flexibility, Our project was very individualized. It was customized. We talked to many facilities individually. We're digging deep into their situations. And what I realized for myself, not always it's about numbers, figures, statistics, whatever, number of declarations, budgets, packages, and so on. Because like among our facilities, we have Siverska Hospital that was evacuated to Zhovti Vody. Only 3,500 of clients they have now in Zhovti Vody. But the changes that we have for medical staff and what we did for those, they provide services to IDPs as well. It's felt much better than just some figures and graphs and some statistic diagrams, whatever. So anyone is important, and if you can make changes for the facility, thank you. Alyona, okay, yeah. Through the prism of public health, prevention, non-infectious diseases, vaccination, and so on. Well, today is not unfortunately a priority for people, and we spoke a lot about access, availability of services, but huge focus should be made on demand. We need to raise the demand for it, and this is the reality. When we have these constant bombardments and the war is still there, these preventive, well, prevention is not a priority for people. Prevention is not to die, staying alive, getting some income, retaining your family. So this is a very harsh situation, and so many challenges we have today. Medical community have a lot of challenges. They have it, like how to help people to improve their health and prioritize prevention per se. Thank you. So if you allow me, I will take a minute. I took notes. I noted some key stuff just to highlight when you finalize. Human-centered, community needs-centered, studying the needs, of course, strategic planning based on the research and study. Interesting aspect on training and education, yes, because initially people have to be prepared to it, that they have to work together, interdisciplinary approach, and planning. Thank you so much, and a round of applause to our speakers. Because I don't even know. We're almost there. We finished the panel. It's almost 2:30. I'm fascinated by our speakers who actually stick to timing that well, not just experts in their fields, but also great speakers as well. Okay, we have coffees, teas, whatever, yes. So we can continue this with informal talks. At 3 p.m., I really want you all to return. Yeah. 5 minutes earlier for us to start on time and to work productively. And the next panel, integrated care at the level of community, challenges and opportunities of implementation during the war. Integration as an approach to restore services. Please, I want you to return on time. And if we have a raid alert, we go to shelter. And coffee is in the same place where lunch was.
Їхньої взаємодії є надання людиноорієнтованої та комплексної допомоги й підтримки конкретній людині або групі людей відповідно до встановлених потреб. МДК може складатися з сімейного лікаря, медичної сестри, соціального працівника, психолога, представників інших організацій та установ, а також членів сім'ї пацієнта за потреби. Ці фахівці об'єднуються разом, щоб надати своєчасну, скоординовану та якісну допомогу тим, хто її потребує. Співпраця в мультидисциплінарній команді дає фахівцям краще розуміння потреб людей. Вони бачать їх з різних професійних перспектив своїх колег по команді, а тому їх послуги стають якіснішими та краще відповідають потребам людей. Мультидисциплінарна команда впроваджує цілісний, інтегрований підхід, який полягає в тому, щоб вчасно помітити не завжди очевидні ознаки вразливості та потребу в допомозі. Адже вразливою може бути будь-яка людина, незалежно від віку, статусу чи стану здоров'я. Саме тому мультидисциплінарна команда об'єднує різних фахівців, щоб максимально ефективно застосувати їхні знання та навички і забезпечити якомога кращі результати для людини. На кого орієнтована мультидисциплінарна команда? Відповідь на це запитання дуже проста. На тих, хто потребує комплексної, безперервної та доступної допомоги. Це можуть бути і дорослі, і діти, а також люди похилого віку. Однак інтегрована допомога є особливо ефективною для людей з комплексними потребами. Для чого різним фахівцям об'єднуватися разом? Об'єднання зусиль навколо потреб людей сприяє утриманню їх у системі допомоги, вчасно надати медичну допомогу, успішно завершити лікування, попередити виникнення складніших проблем зі здоров'ям, посилити прихильність людей до системи охорони здоров'я. Адже поняття здоров'я є комплексним і включає не тільки фізичне здоров'я, але й ментальне та соціальне. Як створити успішну мультидисциплінарну команду? Для цього недостатньо просто залучити кваліфікованих фахівців. Передусім, вони повинні бути об'єднані спільними цінностями та баченням. В команді має панувати відкрита атмосфера, яка базуватиметься на взаємопідтримці та допомозі, прагненні постійно вдосконалюватися. Результатом діяльності такої команди буде комплексна, безперервна та доступна допомога для тих, хто її потребує найбільше.
Панове, будь ласка, збирайтеся, заходьте уже до...
Ladies and gentlemen, please take your seats. I will give you a couple of more minutes, but we don't have much time because we have to work for 1 more hour, and then right after this hour we'll have another hour for a discussion. So we don't have much time to get together after the coffee break. So you had some rest. Let's get back to work.
Панове учасник.
Ladies and gentlemen, panelists, speakers, please take your seats in the first row. In the first row, please. I will introduce you and ask you to join me here. But I would like everybody to see you. Oh, thank you so much for the silence. Last time, it was much harder to ask you to do so. So, we start our next panel discussion. So, we are working for 2 hours, no breaks. We have 1 hour for the next panel session. So, the topic of the next panel is integrated community-level assistance, challenges and opportunities for implementation in work conditions, integration as an approach to care recovery. So, the speakers are Vasil Strelka, Director of the Department of High-Tech Healthcare and Innovations, Minister of Health of Ukraine.
Vyacheslav
Negoda, Head of the Office, Congress of Local and Regional Authorities, under the President of Ukraine.
Olena
Kulchitska, Advisor to the Minister of Social Policy of Ukraine. Stella Georgitsa, Health Operations Manager, WHO Country Office in Ukraine. Kristina Pak, Economist, World Bank Ukraine Country Office. And Vladislav Odrinsky, Strategic Healthcare Advisor, USAID Health Reform Support. So let me explain to you how we will work. We'll have 2 rounds of questions, and I do hope that we will be able to ask questions. Who shall I ask? So that our online viewers, Mr. Vasil, maybe you take this seat. Yes, and please sit closer. For us to make a big and good picture for our online viewers, because many people follow this conference online. So, we will have 2 rounds of questions. The first round is as follows. I will approach each of you, and you will have 5 minutes each. Please follow the timing. And the second round of questions, I will ask general question, not to each of you. And whoever wants to answer, please raise your hand and be brief, because we would like to hear some questions from the audience. So prepare your questions. You will be able to ask them, hopefully. So, the first question is to Mr. Vasil Strelka. The topic of our discussion is eradication of fragmentation and isolation of services at the community level. And what is the MOH vision about the contribution of each provider into the healthcare delivery system? Speaking about the rehabilitation system, well, actually, I would clarify that we mean not only services, health services, but any services provided to people. Because if we're talking about rehabilitation, our task is not just to provide treatment, but we have to help this person get back to normal life. When we are talking about the able-bodied people, it means that this person have to get back to work. And the role and the contribution of the health system is not enough, because if there are some functioning limitations, then we need to engage other sectors. The Ministry of Social Policy, academic sector, and also Ministry of Economics, because we have to remember about the employment of this person. So if this person cannot work, then we need to train this person to take care of themselves. So we start from the rehabilitation, and this is our movement, this is our policy. The situation is different in different facilities. We are far from a perfect model, but we have several providers, like over nearly 300 facilities that provide inpatient rehabilitation, and we have over 150 healthcare facilities that that applied for outpatient rehabilitation packages. Speaking about the inpatient facilities, it doesn't mean that each community should have their own rehabilitation center or each hospital should have their own rehabilitation department. We need to have a coordination and collaboration to provide adequate care. And when we're talking about the outpatient care, it is closer to the patient. The question is, if the person needs rehabilitation, how this person is supposed to reach this place? So if the person is in the village, if it takes time, and it takes time to reach the facility, so the person may not receive care if no one brings this person to that location. So, and also, how the rehabilitation expert could reach the patient if we need to provide home-based care, for example. And here, without the close interaction and without the community-based services, we won't be able, as MOH, as the government, as the NHSU, to provide service to the patient. So, we pay fairly well. The question is to healthcare facility owners. The question is to the community administration. How can you provide access to the services at your level? We have great interaction with social services, and usually we draft our policies together. But we would like this interaction to go down to the community level. When, for example, a patient is discharged from the rehabilitation center and this person needs a wheelchair, for example, then the question, how this person will leave his or her house? Is there any ramps in his or her house? Is the service available in their town or community? And this is the responsibility of the local authority, because we do what we can. But we need to join efforts. So you cannot provide them with the algorithm of how to do it. This is not your prerogative, right? What's on paper, in the resolution, in the order, it has to be available for people. When we say that we play for 10 days of rehabilitation, yes, the NHSU pays for that. If someone receives this money, they have to provide adequate care for, like, say, 10 days. If there is a service for providing accommodation at the community level, then the service should be provided to the person at the community level. Because on paper, we have lots of wonderful things. The problem is in the implementation. Okay. Then I guess I have to ask Olena Kulchitska about that. So this interdependence, this interaction, health sector, health and well-being, what is the role of social workers in the community? And what are the bridges between the health care and social services? We heard from Vasil that there is interaction between the ministries. Maybe you have a vision, a recipe of how it could happen at the community level. Good afternoon, dear conference participants. Actually, I'm glad to speak in front of you. And that's fine. We have to wait? No, we don't have to wait. Great. I believe we just now have a different power supply source. Oops. We have to wait. No big deal. We won't be left without the electricity. Okay. Let me continue. Sure. So 2 years ago, I didn't feel comfortable to speak in front of so many people because I felt the resistance of the healthcare facility managers, the managers of rehabilitation departments when I was talking about the social workers and why they were needed. But it is much easier now because the Minister of Health is talking more about social workers than the Minister of Social Policy. I believe we overcame this barrier. And it was a challenge for us. We launched a pilot project with support of donors. We engaged social workers into the first 14 healthcare facilities into the rehabilitation department. And in the very beginning, the heads of this department said that would never happen. And then when we selected social workers, we trained them and they joined the healthcare facility. So they called us and asked, what am I supposed to do with that person? But now I have a feedback that everything is great. So now this person is our full-time employee. But then you were saying such and such at the webinar. So did we understand that correctly? Because so we have some conflicting vision now. So what I mean, all the rules and norms mentioned by Mr. Strelka and that we try to develop to ensure efficiency. Sometimes we do not see the bottlenecks to the implementation of the standards, and it's the community feedback that is most valuable to us. And we need to know how it is implemented in reality. Because, of course, we can see an ideal picture. Like it's very easy to find a social worker and to hire this person. But then it happens that it is necessary to prove that the social worker is needed by the facility, by the hospital. And you have to prove it not to the facility, but to the owner of the facility or the local authority. And while supporting the messages about multidisciplinary approach, I would like to note that we need to learn how to use a multidisciplinary approach, as it has turned out to be pretty successful. And basically, I'm really happy to hear the feedback from the prosthetics experts, and they call me and they say that the surgeons, they sometimes invite them to the operating room, especially if follow-up amputation is needed. So because they would like to know their opinion to be able to help the patient. And this is a wide range of opportunities to be proposed by social sector or other industries to make sure that the person returns to normal, active life. And very often social worker receives requests that war veterans, after the wounds, they would like to be retrained, and they cannot return for health reasons or for emotional reasons to their previous job. And social worker also have to answer such questions. Social workers have to answer these questions, like where to find this or that service in the community. So the mapping of services is important, the access to information is important, and the social worker has to be aware of all the opportunities for the person so that the person after discharge wouldn't feel isolated and not needed. Okay, thanks, Olena. I would like to remember the first panel summary. I was saying that I could see synergies in terms of how it should be. And to summarize the first two presentations, it was interesting to know that education and the rehabilitation is not limited to social workers and health professionals. Here is the wider range of experts that should be in one team. Thank you. Next, I would like to give floor to Mr. Vyacheslav Nehoda, Head of the Office of the Congress of Local and Regional Authorities under the President of Ukraine. So my question is, what are the barriers in communities to interaction with the social care providers and healthcare facilities, and how to overcome these disruptions at the community level?
Thank you so much for invitation. Thank you. And thank you for really well-prepared questions, specialized ones. I listened to the previous panel, I checked the agenda, and now we're ready. I don't know where I am. I'm not an expert in healthcare. I'm a user. I'm a service user, more of that. And it's so interesting for me to listen to all of this. It's important. So the question, like how to treat diseases, what to take. I don't take anything except water, lemon, and honey, basically. This is just my treatment that helps me so far. So I don't know how it's gonna happen later, but anyway. Okay, I'll try at least to contribute to this. If this was an event on gender equality, okay, colleagues, this is not fair. Okay, look.
Хто нас лікує?
Who gives us treatment? You do. With your smiles, with your attention, you actually help us to get better. So this event that we have today is of huge importance, truly. And the fact that project has been operating for so much time, and I knew little about it, it's my flaw, it's my mistake, I know. And I do hope that this issue and the project itself may be another format, the next iteration, for this to still continue, as the healthcare issue is a cross-cutting one. It's about social protection as well, and it's touching upon the human-related issues. It's of huge importance. Okay, so what I'd like to say upon the occasion. We discuss communities, what should they handle. I remember when we just started the decentralization process, who was in that, who was in healthcare. The district level, or maybe a higher level. And now all this responsibility, in fact, is transferred to communities. And our task was to create capable communities, all right? So just continuing with this topic, I would start it with the following, that our task, our joint task, because it impacts your activity, of course, trying to achieve this for the capacity of communities, institutional resource capacities, not to decrease, but vice versa, because it impacts the quality of all services. We can speak of any access, ramps, roads, whatever. We can talk about buses and so on, but it's the result for the whole community. And for us, it's important to remember. And our joint task is to stand for the idea of decentralization, that the very concept that services that may be provided with proper quality and in close proximity to the person, these must be provided in communities. And this is a foundation. And we need to, many central executive power bodies have to accept this. Those who think that some services, regional level, it's better to provide those, of course. If we talk about healthcare, regional facilities, yes, of course. They should be equipped. When it comes to capacity for service provision, we truly have to increase the institutional capacity of resource capacity as well. Access conditions, something. Okay, for example, with the service payment, the packages, the PHC, the salary, this is provided by the state, this is covered by the state. The conditions where services are provided are of equal importance. And everything here is, in this terms, the responsibility of the community itself. So it's important, I guess now it's important globally because we have, and in the country we have so many relocations, we can't optimize the network. Central bodies establishing tariffs, they have to catch up with the changes. You know, it's a hard issue, it's a problem. And there is even a decision of Congress, a protocol decision tasking the government in these new conditions to find another approach, another coefficient maybe, due to the situation that we have as those regions, Kherson, Dnipropetrovsk regions, Mykolaiv, and so on and so on. Donetsk, Luhansk regions, Chernihiv, you understand what I'm talking about. They have conditions very different from Lviv, Zakarpattia, and other. Problems are everywhere, and taking peaceful time approaches, it doesn't work. Different load, different problems, it's not relevant now. We have to handle it. I will finish my speech now. Our joint task actually is that despite we are in the conditions of war now, our key task is to reach the victory. But victory is made by us, by our defenders, by all of us, and everybody's health is important for that. Civilians, either civilians or helping the military, it's really a crucial thing. Integrated approach that you propagate all the time here. The integrated approach is super important as well. So heads of villages, heads of city councils, town councils, together with local authorities, district authorities, there must be interaction and cooperation. When everybody is sitting in their bubble, no, we will never achieve anything. So the successful result is possible only when we consolidate, when we merge the efforts, and when we raise our professionalism, stay brave, resilient, courageous, and have faith in our future. Without faith, there is no recovery and restoration. Please have faith and you'll be healthy. If you don't have faith, the doctor will fail to help you. Thank you for being that optimistic, actually, Vyacheslav. Another advantage of integration approach. Okay, look. You would never be taken to doctor's team with your knowledge on honey and lemon, but yeah, interdisciplinary team, you are so warmly invited to it. Okay. And I want to pass the floor, of course, to Stella Gergitsa, operational manager, healthcare operational manager, WHO office in Ukraine. So my question is to you, Stella. What is international practice offering for integrated approach, okay, at the level of PHC? Or primary level?
Unfortunately, I have to switch to English because I'm not so good in Ukrainian, but I'm learning. So if you don't mind, please put your headset, and we will want to emphasize in my talk the importance of the primary health care as a system. And the World Health Organization country office in Ukraine is working hand in hand with the Ministry of Health to ensure that all policies in the health sector is aligned to the global policies. And we are, in our policies, in the Ministry of Health policies, we are promoting the integrated approach, equitable and equity. And of course, this creates appropriate environment for further development of the health sector. Unfortunately, we are in the situation now when the primary health care is working in two main directions, because we know that years ago, Ukraine did a great job to start the reform of the primary health care. And one of the directions is to finalize, to move ahead with the reform agenda, and the second, to respond to the people across the front line. And of course, when we are speaking about the policies, there are some principles which is integrated in the national policy, is universal health coverage, which means that each member of the society should receive appropriate health care, starting from the prevention, treatment, palliative care, across the life course, without any financial hardship. It's not a simple principle, however, the primary health care system in Ukraine is moving in this direction. And when we are speaking about integrated approach, it's almost impossible to move ahead without whole society. And when we are saying whole society, this means that the primary healthcare system need involvement of any person of Ukrainian society. Of course, there are three main components which I wanted to tackle in my talk. So first of all, primary healthcare is considered as an entry point in the health system. And when we're speaking about the community level, we know how important, because primary healthcare is ensure the services at the community level. That is why one of the main principles at the primary healthcare is integration of service delivery, but with focus on the prevention. Of course, in the previous session, somebody mentioned that it's difficult to promote sometimes in the very close to the front line these principles. However, this is one of the key of the success when we're speaking about healthy population. The second important pillar is going back to the first is because we are speaking about the front line, there are some good solutions which was implemented and supported by the Ministry of Health, like mobile health units, digital solutions, to ensure that the people in the hardship area receive appropriate healthcare services. The second important point which I wanted to raise here is multi-sectorial approach, and this is one of the principles. And saying multi-sectorial approach, I want to bring to the table the experience in Sokolovska, Gramada, and Zaporizhia level. Without multi-sectorial approach, without good coordination, vertical and horizontal coordination, appropriate services is almost impossible. And when we are speaking about appropriate services, I'm not speaking about only healthcare. Healthcare infrastructure, where we have doctors, where we have resources, where our patients is coming for the healthcare. I'm speaking a social component also, which have to work hand in hand, especially when we are speaking about gender-based violence and so on and so on. This means that we are promoting and implementing the people-centered, not patient, people-centered approach, which is another important principle. And the last but not least, which I wanted to mention, is principle is empower people and community, which means that each member of the society has its role in promoting the health, and to be aligned with the Ministry of Health policies, but also with some measures which is implemented by the primary health care system. So once again, the system, primary healthcare system, especially when we're speaking about the community level, have to incorporate all these three main pillars. Service delivery, oriented on the prophylactics. The second is multi-sectorial, multidisciplinary approach, and of course, community engagement, which have to be further promoted.
Дякую дуже, пані Стелло.
Thank you so much, Ms. Stella. Thank you for sharing. Thank you for sharing. And next one will be Ms. Christina Pak. She's the economist for World Bank office in Ukraine. Okay. Please tell us what approaches are applied by the World Bank projects. I'll help you. Maybe we'll... but I think it works. Great. Nice. Everything functions perfectly. Okay, thank you. So I'll repeat that. I'll repeat the question. So what approaches are used by the World Bank projects on restoring the services in Ukraine? Thank you so much. This is such an honor for me and a big responsibility, of course, to give my speech at this event, speaking on behalf of World Bank, of course. Before I actually answer directly the question on supporting services by the World Bank, a couple of words first on how World Bank is operating in Ukraine. What does it mean when we operate in Ukraine? World Bank is an international organization working directly with the Ukrainian government, meaning that all the activity launched by us jointly supporting the events and measures of the government. I'm an economist, as you said, but I represent the healthcare team, and we directly cooperate with MOH and provide the multi-sectoral support to implement projects executed by MOH with our funding. And one of the biggest projects of WB started back in 2015 was related to cardiovascular diseases, its prevention, I mean, non-infectious diseases. And back then, when there were no gromadas, no decentralization, MOH, together with regional administrations, launched these health schools in villages when they invited not only medical staff to talk to locals, not just psychologists, but social services. Back then, when nobody heard of integrated approach, but MOH, back then, via their departments, actually started doing this. World Bank tightly cooperates with international partners. We're grateful for invitation of USAID. We have technical capacity to provide technical assistance to MOH, thanks to Swiss embassy funding. And in particular, in 2016-2018, we had a big cascade research that showed the loss of patients in various stages, screening, treatment, result achievement after the treatment, those results that we should get with proper treatment. And of course, it was even before the full-scale war, before the COVID. COVID aggravated those gaps, deepened the gaps, and our joint research with KSE showed the double decrease of service delivery for patients' requests, and we can see it in results. In the morning, in the first panel, Mr. Lyashko mentioned that how many of the oncology types are ignored. And this is basically a heritage that we have now due to the war and due to COVID. And World Bank today cooperates with MOH, working on big project implemented by the ministry. And first of all, it's about the recovery. Recovering the healthcare facilities, rebuilding the PHC facilities, hospitals, because service provision is taking place there. And with such horrible consequences of war demonstrated in joint research with their DNA partners, we understand that big investment is required. And World Bank has an opportunity to consolidate funding from various partners and help Ministry of Health to recover their system. We also have other resources, other tools to stimulate services. When we can pay the state, we can pay for doctors' work, actually directed to the state budget. We did that as we did with the declaration signing, and today we pay the state budget for certain services provided, for preventive measures, for strengthening the coverage. And it seems to me that today's topic of integration for us, as for the WB team, is of huge importance. In the couloirs, we talked about this, that WB has teams on social protection, working with MSP and our team. And even the topic of today's conference, it was so important because we had a chance to discuss it internally. What can we do jointly? How can we improve the coordination? What was mentioned at the first panel by Mr. Jakub today. Yes, it's so important for us to have this conference. We will think of it inside, between the partners in the organizations. What can we strengthen to ensure that we give better services, that services are integrated, and how can we give an answer to people? Because despite working directly with government, our key beneficiaries are people, Ukrainians, the population, the patients. Thank you so much. Thank you so much. Thank you so much, Christina.
Now I would like to give floor to Vladislav Odrinsky, Strategic Healthcare Advisor, USAID HRS. Thank you for the introduction. I would like to welcome all colleagues at this conference, and I would like you to look at your neighbors and think, what unites you? Why are you here in this one room? I know one uniting factor: changes, because we create the changes. Some of you have joined earlier, some of you later, but we all contribute to this process. Each of you contributes to the process. Due to this synergy effect, we all create new environment for people in Ukraine. I would like to reflect on Vyacheslav's words. He said that he didn't contribute and he was not engaged in the health sector. Let me remind you that he used to work in the Ministry for the Regional Development. And one of really strong documents adopted at that time was about the capable healthcare facility networks. And this order was signed by 2 ministries, which is a rare occasion, when 2 different ministries agreed upon the same. That's what we lack today, when we have 2 reforms, decentralization and health reform. And sometimes they take different paths. So, getting back to communities, it's important to mention that large number of communities are pretty small, under 20,000 people. And these are just 2/3 of all communities. What does it mean? It means that it is impossible to have a hospital in the community because the hospital starts from 100,000 of catchment population. As for rehabilitation services, the same. We cannot have individual rehabilitation centers in such small communities. So it means that we have to move away from the competition mentioned during the first panel session and move towards cooperation. And I believe this conference will help you to understand your opportunities. And again, a few words about the changes, how they happen. So somebody said, at first we said, and we felt the resistance. And that's the first phase. When you approach people and you want to propose some new approaches, integration, or multidisciplinary teams, and people, when they hear about that for the first time, so the first reaction is, who invented all that? Then the next phase is, maybe there's something in it. And then the following stage is just, how did we live without that? From our experience, we can remember many similar episodes. And that's when the changes inspired by someone changed lives. Many things were invented well before us. We have to find all those practices and we have to adapt them to the current situation in Ukraine now. That's what international TA projects are doing, including HRS. We call them the best practices. We engage teams who are ready to work. I can see many familiar faces in this room. We have been working for many years with many of you. And these facilities, these teams, they introduce changes in their facilities and they disseminate their experience and they share their best practices with the peers. So we look at the facilities and the donors look at the facilities that introduce best practices and they are our centers of excellence. And the other international TA projects look at them and try to engage them as well. So we have the environment of people infected with the change virus, and they keep infecting other people. Thank you. So we have 15 minutes left. This is not exactly in line with my plan, but I would like to ask at least one more question. And so whoever wants to answer this question, please, you are welcome. But maybe I should ask people from the audience to ask questions. Maybe it would be better. And if we have more time, then I will ask my second question too. Hello again. I would like to support Vlad's words, and I would like to ask Vyacheslav Nehoda to return to the family, to harmonize the reform in the health sector and the decentralization reform. Because I believe that me and Vyacheslav Nehoda are the only people representing local self-governments in this room. So I am the expert of the health platform in the Association of Communities. So I know that USAID HRS is about to be over, but I do hope that the local authorities could demonstrate appropriate level of commitment and they will agree to be trained. I don't know if we have the deputy heads of the communities, but I believe that they are supposed to be here because this is an important event. What is your question? Yes. So my question and my request is to support all communities, and my request is to support capacity building of the management of communities. And now we understand that the local communities, local governments have a large workload. And then we have to understand if their authority is relevant. So, thank you so much for your question. Well, actually, you introduced yourself twice, and I heard your previous presentation, and you're promoting your association well. Congratulations. And I know many Ukrainian and and all Ukrainian associations, and I cannot remember your association, but I believe it's my fault. So as for returning back to the family, I didn't leave it actually, and but sometimes it happens. I don't actually understand what you meant. I believe that we are all one family, one big family, and we are all Ukrainian family, and we have to be united, and we have to feel that we are all together. And I don't really like any speculations, but again, I'm moving to politics, sorry. So I didn't have enough time, but I would like to say that our main task, like I said, it's to build the capacity of all communities and all local self-governments, because to add extra authority, extra responsibilities. I don't remember if there is anything like that in the health sector, but in other areas there are many discussions, like privileges, social care, and other things, and it's another workload for local governments. Well, of course we can do that, but then we need to provide them with the means to cope with that. And we may have a nice car if the road is free, and but it is small one if it's a small car, and it won't take much. So, in terms of the luggage, when you're talking about the authority and mandate of local self-governments and the delegation of responsibilities, of course, it has to be supported with resources. I can delegate something to you as well, do this and that, no problem. Just let's have an agreement and you have to pay for me. That's how the government should address the local self-government issues. The taxes are the results of work, but then the motivation is lost if the taxes are taken from you. Just imagine, you have your payment, you go to the office, but the taxes are so high that your salary is not enough. to pay taxes and to survive. Of course. But Vyacheslav, please, wind up. I didn't hear your question, by the way, but I share your opinion. Basically, I'm in one family, and I will ask you more about your association. And one more thing. I would like to ask the audience, please, ask brief questions. This is not for you. Please introduce yourself. Good afternoon. I represent that particular self-government. I am an MP. I am a member of a standing committee on health in Vysochine Town Council, Kharkiv Rayon, Kharkiv Oblast. What's your name? My name is Victoria Demechka, and I have another responsibility. I'm also the head of the social welfare unit of this community. And I would like to say that we have enough competence at the community level, we have enough knowledge, but I would like to thank Mr. Nehoda for what he said. Yes, lots of responsibilities are delegated to the level of town and community authorities, and we don't have budgets for that responsibilities. So one of our requests to all participants, unfortunately the ministers have left, but it is important to revise some subventions, some subsidies for the development of local communities, especially for the communities that host IDPs and evacuated people. Well, in our community, we have over 24,000 of people. So we have over 17,000 of IDPs. So these people, nearly 3,000 people got registered with healthcare facilities. The overall number of IDPs is nearly 1,900 children. They're always here. We have 49 large families. We have many people with disabilities, many senior-age people in need of care and palliative care. And in the Kharkiv Oblast, the facilities that provided palliative care, they're closed. I mean, inpatient palliative care. And they cannot admit those people. So this support that you mentioned is critical. We need it. Yes, at the local level, all communities support health programs. We have cancer program, TB program. We have a program for hemodialysis, for rare diseases, and all those programs. And the people can receive free treatment, and they also are funded from the local budget. And we do not deny any support. Please ask your question. Well, yes, we ask all those distinguished people and representatives of international TA projects and representatives of NGOs. We collaborate with international projects. So you call for collaboration, yes. And second, we would like you to approach the Parliament of Ukraine and approach the president with a proposal to revise the financing for the communities. Yes, we heard your question. And we appreciate you sharing, but we have some time, and I believe that the speakers... Yes, please. Yeah, I know that someone has to leave. Some of the speakers, Ms. Christina Pak. Yes, thank you for your participation. We'll let you go. I can start answering. I can give brief answer to Victoria's question. I know that many of you share her opinion, and that's a problem. And that's what was said during the previous panel sessions and what Mr. Nehoda was saying about the capacity. This is about the capacity, and this capacity in health, it is a particular capacity. All those things like hemodialysis, palliative care, it's related to the population size. And the world experience shows that it is impossible to create services for that number of people. That would be a huge workload. That's why several things are moved to the national level. And each country has its own path. Some programs can be local. Some programs have to be national. Because if there are several patients in need of high-tech medical treatment, it could eat all local budgets, all local program budgets. So highly specialized care has to be provided at the national level. So for us to understand how to finance these programs, we need to run discussions. We need to have platforms and forums to discuss it. And this is not the question for the parliament. This is not a question for local authorities and communities. It has to be discussed widely. So, and the communities believe that once they are decentralized, they can live in isolation. But when we realize how cooperation could help us, it would mean that the communities will enlarge, and then not one single community will maintain a provider, but several communities will maintain a network of facilities. So I do agree with Victoria, and so this issue has to be additionally addressed, and it will require the national level contribution as well. So the problem is that people, to do the testing and screening, they have to go to Kharkiv. So Victoria is saying that people who cannot receive care at the community level, they will have to move. They will have to move to other places. And so these pathways, these extraterritorial approaches mentioned by the leadership of the MOH and HSU, that's what saved the system after the beginning of war. We have managed to preserve many services, and we kept them uninterrupted. Anyone wants to add something? Yes, I would like to reflect on it a bit. Very good remarks. And in the ministry, we started thinking about it like a year ago in the context of the following. The provision of social services according to the legislation is the responsibility of the community. And we understand to request the whole range of 43 services would not be reasonable. So several programs needed national level support. And actually the government supported the creation of the network of shelters for the victims of home violence. And the communities face challenges that in many communities, not only frontline communities, but also in the communities in the west of Ukraine, they didn't take into account that number of providers when they developed their network of service providers. And the need in services is sometimes extraterritorial. When people move fast within one fiscal year, so it's impossible to move some part of the budget from one community to the other community. It's pretty hard. So we are working on developing the basic social services package that the person is entitled to in the community. And if there are enough providers, we understand that some services could be pretty costly. So we will support these communities. And right now we are implementing pilot projects because we need to have certain budgets for that. But we have 1 billion UA for such services in the state budget. And you all know about one of the projects, basically the life sustainability project. And next steps is monetization of the inpatient care. So the services, when communities feel problems and feel they cannot do that on their own.
I'm grateful to each and every panelist. Thank you for finishing in a constructive flow and manner. Yeah. Okay, so just to draw the line under this discussion, as usual, what do we see now within the conference? Ministries cooperate. Donors cooperate. Okay, we've seen it even a separate panel for that. Despite the support at national level, it's hard to tackle the fragmented nature of services provided at the level of communities, but I want to still finish in a positive manner. Okay, something I want to reach. It's a process. There is a single vision, and there is a wish, to build the process. The key principle that must be adhered to, the statement, human-centered system. Okay? This is a process, and I do hope that we are actually moving towards this. From what I heard, all these statements, yes, I think we're on the way, we're not stepping out. Our biggest gratitude to panelists. Okay? Thank you for your engagement. Thank you for questions from the audience. Thank you. And I jump to the following panel instantly. Okay, we don't have break now, so no relaxing so far. Okay, the topic of next discussion that we have. Okay, we speak of the nursing development in Ukraine. Strengthen the role of nurse as an important component to restore the access of people to services. Okay, and I would love to have our key experts, those helping the nursing to actually develop. Alina Nikonchuk. She is the medical science sector lead, Department of Medical Personnel Education and Science, MOH. Katarina Komar, Director of the Center for Nursing Development in the Ministry of Health, please. Ms. Alla Boyka, Senior Technical Advisor, USAID Health Reform Support, or HRS. Mladlena Kachurets, are you with us? Of course. She's representing Ukrainian-Swiss project, developing medical education. Yulia Babenko. She's a nurse at the primary healthcare center from Bucha. Vita Zhukova, the nurse at the primary healthcare center number 4. This is Kryvyi Rih. And of course, we have Oksana Jam, the chief physician of the primary healthcare center from Bucha. Okay, we have an hour to work. I think we still have some extra time because after that we have the goodbye coffee, just to finish it with some informal conversation with those we met today, just polish our reflections and maybe talk on some new ideas that we heard here. Okay, and of course discussing questions. Okay. The focus of the discussion is how can we simplify and extend access of patients to services via establishing new roles for nurses. Okay, I address my first question to these two people representing MOH and the Nursing Developing Center, Ms. Nikonchuk, Ms. Komar. Which initiatives currently are implemented to automatize the nurses' functions, for actually have an autonomous specialist made out of nurse. Thank you for inviting me. Well, today I want to start my speech with this in the context of discussing the autonomization of the nurse's role. Okay, we've had this news coming up an hour ago. Today, in the first reading, Verkhovna Rada supported the draft law on self-governance in healthcare sector in Ukraine. Why it's so important, why I want to start with this issue? Because when we establish this self-governance model in Ukraine, as we have it in the world, you know, with the best world practices based on these, it will allow us to create conditions for autonomy and for economic freedom, primarily for healthcare sector employees, including nurses. Because for them, we have a separate organization, separate self-governance model. What will it give to professional community? A chance actually to impact the decisions in healthcare sector, okay? They will be entitled to be engaged in handling the issues related to professional development, not by bureaucrats sitting in offices, but people doing things, you know, peer-to-peer assessments. When we have a mechanism to protect rights and interests, okay, of professional community and patients both. So this decision made by Verkhovna Rada is really, it's a watershed moment. And I do hope that it will be like fully adopted and self-governance will develop and professional community will evolve. It will enhance its capacity and start shaping the policy and defining the healthcare evolution areas. But we're still on the way to self-governance. We have to start changing it now, not in a fragmented manner, but comprehensively. So together with the team, with the project representatives, with the colleagues we actually have now in this panel discussion, we started drafting the framework document, Strategic Areas on Nursing Development. And this document will define the foundation of 4 blocks, so education, employment, leadership, and service provision. We'll actually define the key concepts and key changes that we need now. And that's where one of the key areas that we put, extending the duties of nurses, their autonomy, defining new roles for them. And of course, we do not need to take the nursing model as a format where all our nurses have like the same package of functions and the same list of duties and powers. We have to revise this, okay? So we actually work on that. As Mr. Lyashko mentioned in the morning, we also started working on the concept to create the nursing care hospitals. Establishment of those hospitals will allow to unload the healthcare system at primary level, and of course the specialized care units. And it's so important, and we need the vision of professional community. We want to hear your voices. We want you to give the impact. That is why today we give the key role to our colleagues in this discussion, for them to share how they operate, how they practically implement this. For all the papers that MOH is working now on, for these documents, for these acts to be implemented. So we move forward, we see the light in the end of the tunnel. It's not about making these fragmented, okay? It's not about, using this fragmented approach, but we have to get this comprehensive nursing development model in Ukraine. Okay, Alina, it's like you already made a conclusion. A round of applause, I guess, to ladies in the center, because doctor and 2 nurses we have with us who actually came from the regions to share their expertise. Yes, and I would love to focus on this, okay? A round of applause again to the ladies, and we will have this emotional moment as well. Katarina. Okay, you can continue. Okay, first of all, the new nursing model. Center of Nursing Development was established in 2019. The key goal was to present the new model of nursing. And today, it's June 6th. With our USAID colleagues, we had one of the joint conferences held on extending the powers of nurses in PHC. It was 5 years ago, specifically like on this day. And this is like a holiday. It's a holiday for me, a personal holiday for me when Verkhovna Rada voted for the draft. I am a nurse. It's my even first record, in my employment history. I started with this profession, and we can't speak of nurses without nurses, all right? So this is a very good tradition, and now it's becoming a routine thing when nurses are telling about themselves. A separate, let's say, chamber among these five will give us chance to autonomize the profession for nurses, and it's not a surprise, now that we do talk about nursing professional, like a separate service provision unit, okay? Our joint strategic document we work on, practically all the colleagues may be WHO engaged as well, Swiss project, USAID. We all, even nurses, are engaged in drafting, and I just want, it will take me a little more, but this will not be a presentation still. We envisage education. We have this pre-graduate, postgraduate, and of course the lifelong education or continuous professional development. Of course, for education, I want to say that in Ukraine we already have bachelor's, master's, that, but we also have PhDs, doctors of philosophy on nursing. 3 people we even have, yes, and it happened in 2023. The first one in February. In February, at our practical conference in MOH, the minister, the deputies met this woman because it was the first, like the pioneer. But before that, they had 3 years of postgraduate training. Now, in PhD, it's 4-year curriculum. Now we have 20 people, 20 students. These are people working in hospitals, so chief nurses and also directors in nursing, deputy directors in nursing are there, as we call it, managerial positions, yes, in nursing sector. So among these postgraduate students, we have practitioners, nurses who actually have enough time to do both. One of PhDs, she's an associate professor even, on actually nursing. This is her subject. So our framework document has a huge perspective, it's a colossal scope for implementation. I want to stop at professional standards that we design right now. The center is designing these 37 professional standards directly and 21 standard together with the Ukrainian Federation of Professional Medical Associations. We create this profession from the scratch, okay? Professional standard is a list of competencies which are required to perform some functions, okay? And educational standards, this is a list of competencies acquired during the training. Okay, why mentioning these definitions at a practical conference where we have communities? Guidelines 88 that you use when you make any records in the employment histories, it's already obsolete. What it's replaced with? European standard. It's called competence-based approach. In education, it happened 5 years ago, but the key idea is that those functions that nurse is performing at her workplace, these are described, split into actions, competencies are picked. These 5-6 key competencies later have to be in the standard, educational standard. It's a mechanism for education to cover the practical needs, okay? Very clear, very applicable, and these competencies are designed by nurses. We have 12 working groups with 160 people from all around Ukraine. But when I see the slides in the presentation, Kharkiv hospitals we have, Lviv region there as well, Zhytomyr and Kyiv city, educational establishments, colleges, departments of universities. representatives of education, practitioners, trade unions as well. According to the law, they should be all there, but geography is super extended. It's taking place now, okay? I was sitting in the room, and usually it happens. I got a message that another application is approved to extend the powers. New positions we'll have. I will not announce the new positions that we do see at PHC as well, because this all will be the framework document. I really want to spill it out, but no. With the practice, what we call as job, yeah? It's motivation, of course, when we say the word salary. Yeah, formal and informal motivation. And the mechanism that salary depends on the collective agreement, well, yes, it depends. It depends. But you need to know how to use this. And it also, in the document, how to implement. Clear analytics. And the requirement in nursing staff, and we need that for full planning, of course, of human capital. Education at workplace. Training while working. So a nurse is training a nurse. It's about leadership and mechanism of service provision. I can talk for hours, but you have to stop me, yeah. Maybe if we have questions from the room, I will give the details. We had a conference with the partners, and after that on Facebook I read that I was quoted, but I really like that out of all speech, it was really, people really like that. Difference between nurse and doctor. Nurse is giving the care, and doctor is giving the treatment. Two simultaneous processes aimed at patient's healing. We speak about treatment a lot, what doctor is doing, but we also start talking and implementing this in legislative acts. What nurses are doing, taking care, okay? Thank you. Thank you so much. And we move further. My question is to Ms. Oksana Jam. Ms. Oksana, you are the chief doctor of PHC Center. Okay, you have some experience already on how to put that all in practice. Okay, tell us. Yeah, good afternoon, ladies and gentlemen. Search for new tools to improve the quality of healthcare. It's ongoing, especially when it comes to PHC, because primary level is the basis, you know, the self-care, and also establishing cooperation with communities. This is really important. And today, we shape new senses for such a profession as nurse, okay? Because nurses' new roles, autonomy, in the state and in our facility, this function was not revealed properly, I can say that. And we all understand that nurses were in the shadow of doctors standing there all the time, and let's say just a technical performer or executive, some tasks given by doctor. But when the reform started since 2018, the PHC has been developing, and a natural process occurred to distribute the roles between doctor and nurse. And we clearly in our teams understand what doctor is doing, what nurse is doing. This is the segregation that definitely strengthens our activities. Nurses organically fought for their autonomy, managed to fight for it. And nurses became independent players or subjects, and now nurses feel the level of professionalism one can provide while interacting with a patient. When at the level of facility, we realized in the team, doctor, nurse, that such actions are possible, distributing for strengthening. When the majority of managers at PHC who implement this in facilities, when they understand this, when teams understand this, that nurses get a different status, when, of course, this is extended in communities. Because in communities, we have to provide more powers to nurses, for them to participate in various coordination councils, projects, handle analytical tools. Of course, then patients will realize that this potential is important, that it's about professionalism, and then people start perceiving nurse differently. I am also a nurse. So I'm a college graduate. I have some practical experience. Later I became a doctor. But I understand what that is when patients trust you. Sometimes patient even during the visit one wants to see the nurse more, to share something. And nurse actually already is in this interaction flow, providing support, providing care. This is really important because these fast interventions can actually help us to strengthen the role of primary healthcare in the facility and at the level of community to perform the function of high quality medical service delivery. Now it's the moment, actually, when all this should be unified and officially regulated in legislation. When there is understanding, I think that this interaction will soon take place. I thank you, colleagues, for actually bringing this to the surface, because this understanding at the level of facilities and teams, it's already there. And we are ready to full implementation of new roles and introducing the autonomy of the nurse. Thank you, and a round of applause. Miss Oksana, it seems to me that we definitely have a tradition to trust the nurse. A personal story. By 6 years old, I lived with my grandma in the village. There was no hospital, no doctor, but there was a nurse, and she was so respected. She was a respected person there. And she handled so many issues, medical issues and problems. Everybody was coming to her, and she had the reputation to say, okay, like, dear grandma, now you go home, you pack, we'll call the ambulance and so on. Nobody could force the grandma or grandpa just to pack and go to hospital. Only the nurse had that power, actually, for them to obey. And she had a phone, so she was really, she had a phone connection. She was a respected person. She gave calls, and these people went to hospital. It's actively implemented in rural areas where there is a huge trust to nurses, and just like in our establishment. The quantum leap is for nurses in villages. We have results, we believe in that, and it's a mechanism that's functional. I want to talk to nurses now, Miss Yulia Babenko and Miss Vita Zhukova. I have a question to you. You have experience already on autonomization. I used the word automation instead of this. Sorry, this is like, it's already yes. I'm too much a verbal load. Autonomous activity. Less of syllables to have there. Okay. Tell us about the experience. Will these initiatives promote the expansion of your capacity, the expansion of your role? I want to share our experience, okay? So I'm taking patients autonomously, patients directed by the family doctor to me for consultation. Still, we don't have this like official appointments to nurse, but we plan to do it like this to organize it better. I have patients coming. I have preventive examinations taken to identify groups of risks and I have fast interventions, talk to people about smoking, obesity, cardiovascular diseases, diabetes, and also the healthy lifestyle and physical activity. All these interventions and consultations. I have my own personal nurse's office. I have my own digital signature, so I make records of all the consultations with my signature. So, for example, if I vaccinate, I also put the records in my office with my electronic signature, and I can plan the vaccination in my personal office, nurse office. Well, this is my experience, actually. Okay, we do it differently. We have electronic recording system with appointments to nurses and doctors.
So we have a call center where our staff members, they're very competent. They can refer a patient. If a patient needs a doctor, then they can do that. So the patient can choose appropriate time slot, a day and time. Also, there is a calendar with time slots to me as a nurse, so the patient can choose preferable time slots. So our rooms are adjacent. So the doctor has his own room and I have my own room. So in the morning, I do sampling, and the patient can see a doctor or me. If I just do blood sampling, then it takes like 10 minutes. And the doctor issues a referral for a blood testing. And if a patient needs ECG, then the doctor could give me more time. And I could also do the ECG for the patient. And the patient doesn't have to visit me several times. So when the intervention, when, for example, cleaning is over in the morning, then I spend 15 minutes with each patient. What can I do within this time? I can refer to chest X-ray. And yes, there should be trust in the team. So what about the prevention, like healthy habits, healthy lifestyle? Well, yes, of course. If a patient comes and does blood test and I can see that the blood glucose is higher, then we have to do the test again. And if the patient has diabetes, then we need to talk to a patient to explain the healthy habits. And we have the health school, and I can recruit patients. And we have several people. We have the electronic waiting list. So if people want to join it, we have a schedule, we have topics. Yes, we organize such conversations with patients. And also if a person needs medical and social examination, then or disability determination, then the doctor doesn't need to produce a referral. That's my task. Also, I manage patient files. I plan vaccines and vaccinations. We have a special vaccination room, but we do it. We refer to vaccination, and we call adults, we call children, and then I use my digital signature, and I also take data and add to the patient files. So I would like to ask some members, some participants to keep silence, because I wouldn't, please do not talk at the same time as us. So, my next question, do patients follow your recommendations? I wasn't sure if I should have this independent patient visits, but our people surprised me. They ask for appointments, they visit me, they follow my recommendations, and I have to say that these different trainings on strengthening self-esteem, well, that's my individual patient visits. Yes, people come, but another important thing is that when your doctor supports you, delegates some tasks, that you work as a team. And when doctor recommends you to the patients and says you have to talk to the nurse as she knows more about that than me, then of course the trust grows and the nurse feels more confident and they're pretty confident in recommendations. And I would like to get back to the previous question. So these initiatives, so you know about new policies, new initiatives. So tell me, do they empower you? Well, yes, because we're doing our job, but the legal aspect of enhanced nursing, just to have it all properly regulated at the legislative level, it's important, as we all have to be legal and to act legal. Well, in 2023, the administration of the facility developed the quality criteria that includes an individual visits of patients, and we are paid extra for that. Thank you. Okay, let's move on. And I have a question to Ms. Alla Boyko and to Ms. Madlena. So, what are the initiatives of international TA projects to enhance nurses' role? Thanks, Oksana. I'm really happy to be part of this panel, and we are saying nurses, but 97% of representatives of this profession are female. And I believe that, as you can see, we're all females here as well. So I'm happy because I'm part of a team of big dreamers, the HRS team. So when we started the project 5 to 6 years ago, we were saying just, well, it would be good if a nurse could work independently, like it is in the well-developed health systems. And now I'm here sitting next to nurses who say that, yes, we are doing this, and it is simple. I know that they're nervous. I know that it was hard for me to convince them to join this panel and to present themselves. So your applause and your support for them is important, and this support is for you as well. Thanks for convincing them. Well, speaking about HRS and our team, the team of dreamers, those who believe in people and changes, what we're doing, of course, we're working at the national level with the MOH. We closely collaborate with the Olena and Katarina, and what we announced today, the strategic areas of nursing development, I believe this is like a small revolution in the health sector in Ukraine, because a nurse has more power now, and this document lays foundation for changing the role of a nurse. In addition to that, we work with healthcare facilities, and now I'm going to talk to the communities present here. Why did we decide to propose to the communities, as part of our RPC program, the independent nursing or enhanced nursing component, as this is another powerful channel that would link people to care? One of the big problems and challenges that we faced is that the people are disconnected. And people trust nurses. Nurse is closer to the patient. So we propose 25 PHC facilities from your oblasts to be part of this program that would include several components. First, work with management teams. And these management teams in PHC facilities will be supported as we propose to them the plan for the implementation of independent nursing in their facilities. Without the support from the management teams, it would be hard for the nurses to be independent professionals. We will work with doctors. We will train them as if there are doctors in the room and they work with nurses. So imagine you say to them, well, your nurse will be now sitting in a different room. She's not yours. She's independent. And a doctor can support nurse in this enhanced nursing. But at the same time, a doctor could be a barrier because they got used to working together with a nurse. So we are going to work with doctors as well to create the synergy at this level, the partnership, not subordination. And of course, we will have trainings for nurses, and we will help them. We will help them to provide counseling on NCDs. And colleagues were talking about that, and Yulia was talking about this NCD counseling. And in addition to trainings, we will provide supervision and to the HCF management and nurses. So we hope that your facilities will join our efforts, and we hope to succeed, because a nurse can do much more than she's doing now. We have just to create conditions for that and believe in her. Thank you. Thank you. And we've heard a lot of valuable opinions in terms of what has been done, what is to be done by the ministry, by international TA projects and healthcare facilities. In the Swiss-Ukrainian project on the development of medical education, well, that's the primary focus of our efforts, the medical education in Ukraine. Nevertheless, there are many side activities, like satellite activities, that affect the content of education and other approaches that could be used for education. When we're talking about the nursing, so one of the activities in our project is aimed at strengthening the capacity to provide care at the PHC level, and of course that the nursing is an integral part of the quality of care, especially in the communities, especially at the PHC level. Well, first and foremost, when we start some interventions, we do the assessment to understand what's happening in the system right now and what could be the most efficient and rewarding area for interventions. So in 2021, we prepared the analytical statement on the status of nursing in Ukraine and on the possibility of enhancing the nurses' role in the PHC facilities. And I would like to emphasize why these studies and assessments are important, because we could have some baseline indicators. And then, in a while, we could do a follow-up study to understand what worked, what didn't work, and if we have any improvement. So one of the key findings was that, according to the legislation, in terms of the barriers, In fact, there are not so many legislative barriers to enhanced nursing. As of now, the legislation and the nurses' qualifications say that the nurse works in the PHC team. The nurse is supervised by a doctor, and this is like more about the understanding of what this doctor's supervision is, and how the doctor-nurse team is working. So one of the conclusions for us was that one of the biggest barriers is the culture in the facility itself. So soon we will present the concept of the changes of culture in the facility itself, because we wouldn't like to segregate nurses, and we wouldn't like to cover only nurses with our activities, because it is more about the attitude of the community and the management of the facility and the doctors. So it all depends on the organizational culture and the values in healthcare facilities and in the community. So also a little bit of reflection on standards and education mentioned by Katerina. Yes, together with colleagues, we are working, and we hope that this document will be quickly adopted. And this is the document about the professional nursing standards. So this is like a follow-up process and follow-up document. After the description of the range of services provided at the community level, at the national level as well, at the regional level too. So without this baseline analysis and definition of what the nurse is doing and what should be done by a doctor and how it should be identified in the community, I believe it would be prematurely to talk about some professional standards. And the other thing is about the education. So education is not just to meet the needs of the industry. Education is more about the outlook. So this is not just to train someone and to transfer some knowledge. This is also about the outlook. So the project activities are aimed at educational facilities like nursing colleges, and we have several pilot projects for nurses, and we also train professors there, and we also do the training on the approaches to training and education, because the content of education can change quickly. But if the professors do not believe in modern approaches and are not aware of them, so no matter how hard we try to describe some requirements in some nice documents, so it will be distorted. So finally, about the implementation, we have pilot PHC facilities, and we selected them from multiple regions of Ukraine, and we organized training for nurses on hard skills, soft skills, to strengthen and to encourage their professional development. And we also would like them to feel more confident and be brave in fulfilling their dreams.
Thank you. Thank you. It seems to me that we have this tone of discussion was very relaxed and sometimes even emotional. And now I offer you to have some productive activity and concisely
Два запитання, так? Які
Verbalize the answers for 2 questions. What barrier do you see and how to tackle it? Very simple for us to concentrate on constructive things, okay? Who's gonna start? Or shall we do it like in a row? In a row, okay. You know, when I listen to colleagues today, thank you, by the way, for sharing. I think that it's more not about barriers. It's, well, we don't see barriers because we do see that professional community is infected with changes, as Vladislav's saying, because it's important. When the community itself wants to change, then politicians give us the policies which are implemented. It's not when it's forced, okay? It's not when you are pushed to do that. It's when people strive for changes, move towards changes, and they don't see barriers. Okay, I'm pretty sure that we'll successfully do it. Okay, you know, I'll give the answer in the same tone, because in policy designing we have this window of opportunities, yeah? A concept. And there a time comes when you can implement something which was already there, you know? You can't do it very fast. There's a chance to implement something. If it wasn't done before, you can't do it fast. If you didn't have some previous preparations. I loved the speeches of my colleagues. People from hospital. The practitioners, I love that. I was just taking notes. Because evolutionary need for autonomy of a nurse, you know, of course, it all comes from abroad. We all know about power extension, advanced needs that we can and we have to give them more powers. But now, thanks to healthcare reform, thanks to funding system changing in communities and in facilities, in secondary hospitals, specialized ones, they entered later, but still. We feel this colossal need in autonomous nurses. Everything we do for patient. We don't do this just because someone's cute, okay? All the policies in Ukraine, it's not that, okay, do we need firemen, like fire people, you know, fire extinguishing brigades, but it's done for something. And in this specific case, all evolutionary mechanisms proved us that nurse autonomy is required for medical service delivery, so you don't see barriers on the documents. To organize a separate appointment, nurse's appointment, all this time it was there in the guidelines that we adopted even in Soviet times. The chance to have a separate appointment organized by nurse, and it's true. It's more for organizational activity within the structure, within the facility. But what I loved from my colleagues, this digital key. By the way, many didn't notice that. In 2021, Minister of Health, Viktor Lyashko, not just like a minister, but it was his personal idea, you know, not because of his position. He said that we will take steps. Well, let's start with small steps, he said. It was a small step before the war started, when they made it possible to have this separate digital key for the nurse, but you do need to know how to use it. When you do it already, I hear this, it's super great. Because in this case, system can see what you're doing, not for the doctor, but personally. It's important. And of course, these are not barriers, but it's for us where to work for this experience to be disseminated. It's a point of growth. Somewhere it's acceptable. In some places they have these functions. Somewhere it's limited, but if we speak about primary level, this is something that we need to develop. I see many barriers. Well, legalization, I spoke of this when I talk about that. Okay, one of the barriers, funding of facilities to create conditions for this for these nurse appointments, for the nurse to do it on her own. Okay? In my opinion as well, motivated nurses, they should be motivated. Without motivation, without those who want to train, those who want to actually handle those appointments, well, nothing will get. And stereotypes in society, for me, this is like the biggest barrier, the most painful one. And for that, we should create some special programs for these stereotypes to eliminate those, for people to understand that nurse can be autonomous. It seems to me with your practice, you actually are crushing that stereotype and barrier. Okay. I think that what can be a barrier? A lack of wish to change something. If there is support from the team, if there is support from the management, then all barriers are defeated. Also, fear of responsibility. It's such a huge barrier. You have to twist yourself and twitch and twist and just force yourself, yeah. Lack of knowledge, maybe. You have to, it's about live and learn approach. People come with requests and you are the one who gives answers to those requests. Improve your knowledge. And you search for something, you Google something, you read in encyclopedias, whatever. So you do that, actually. In my opinion, no barriers in that. There are some implementation nuances, something under discussion. But this whole thing is about communication. It's just a process where you have to start doing. And only when you enter into process, you'll understand and see if result is there. Okay, so I think we'll manage. Now that sounds great. I will not be very original with my answer. Yes, it's so hard to be original. I would stress more on where efforts can be put. More efforts. Even when something is perceived as a barrier, it doesn't mean that this is an Everest. It's something, well, let's say you can eat an elephant with a spoon. Sometimes you need a bigger spoon, sometimes a smaller spoon. Individually, with a team, you can handle that. And you can reach the top and get to the skeleton of an elephant eventually. When it comes to individual experience and success stories and practices, I think you just need to communicate more and at such events, talk to colleagues, telling colleagues about success stories, that this is not so scary. It's not that hard as it seems to be initially. Of course, more of when you, let's say, enthusiasm and initiative generate synergy and the opportunity to find allies and merge into teams. Okay, less fear, more action, actually, and take steps. Don't be afraid to make mistake, because the one who is the perfect one? The one who doesn't do anything. Learn from your mistakes and colleagues' mistakes. Use the experience you have. Read the studies. Read the research. Familiarize the experience of other people and accept the very culture that nobody has to punish you for mistakes, but it's something, it's a growth point for you to become better. Of course, education and training, I have to mention it. It's something that we all together have to push forward, and we need to have more of high-quality educational products in promoting with various stimuli, money, and not only money, to develop professionally. And, of course, organizational culture. Yeah, everything starts with organizational culture and values we use for teams to work. We survived so many, thanks God. Being afraid of just giving extra powers to nurses, this is not something we have to be afraid of. Yeah, thank you. Misala, colleagues, just a little bit. 4 minutes to survive, apart from the nurses' powers. Okay, okay, barriers, like a whole list, but I will not give you the list, of course. So just one thing to mention. Last week we had training for for nurses, for doctors on autonomous nursing. Yeah, nurses said barriers. What barriers? Forget. Don't create barriers for us. Don't obstruct us. Don't hamper us. We can do that. Just give us a chance. So if you rephrase that, like how to handle, I think I'll repeat again my words. What my colleague Mladena said. Supportive environment. Sometimes we do not need super hard efforts to be put, and 100-page documents, but just create conditions for someone else next to you to become successful. If we manage to create those conditions, I do think that in a couple of, but in some years, our nurses will train others, even European nurses, on how to operate during wartime, provide consultations, and be better than others. I have strong faith that at least 25 facilities will work with us, and we'll be able soon to just feel immense pride for those results. Yes, thank you. Ladies and gentlemen, if you do have questions, if you dare to have questions now, you can actually ask those, but I'll give you the mic on my own, all right? We do. Okay. I want you to I want you to be very, very reasonable now, because everybody wants to have some final coffee. Okay, thank you. Just to finish, I really want to finish this conversation, but demand is higher than supply. In our community, Pokrovsky PHC Center took part in this competition for nurse training to extend their powers, and we failed actually to be selected. We have these 5 units, medical units. Our nurses weren't in those 25. When we will be there? Is it possible? So when these applications are considered at the level of centers to engage and cover all the nurses, not just 2 nurses to be taken, but also for this to be a comprehensive thing, for the unit nurses actually to develop and train simultaneously. Then it will not impede the process, but it will help. It's a reflection. It's basically not a question. Then thank you. It's my wish. My wish. If you want to add something, I'll be grateful. I can briefly comment. I, of course, agree that demand is far beyond the supply. Of course, meeting that demand is high. It's high expectation, but it's hard to do. We use some criteria when we select, okay? But always, when the first step is successful, now we go to second phase of project implementation. And based on results of phase 2, we analyze how successful the activities were. And then we have a chance to extend our capacity and engage more facilities. Of course, please don't just lose your faith. Have hopes, because we do everything to engage more and more of those who want to change and help more and more of communities. Please continue applying. Look for some, opportunities, projects. The one who searches is the one who finds. Thank you. Ina, thank you so much. Honestly, it's so good that demand is exceeding the supply. It means that time, it's the time of idea, unstoppable idea. And I don't know if your community and facility applied, if you were in the list of these 25. No. In the project, we always support initiatives, even of those who weren't in the bigger project. Let's talk more later, okay? Maybe some other facilities are there. Zoom will handle everything, any kind of audience, so we can have any session and tell whatever. We can contact you with chief doctors, including Oksana, who are doing this. It's possible. It will not be offline, of course, unfortunately, but in Zoom, that's like 100%. Allah, thank you. It's so nice again for me, useful contacts and network expansion. Now we will have this cooperation eventually. And Andrei has a remark. Hello. I just want to say that you are you're doing some good stuff. Okay, you're cool. The nurses, the chief doctor that supports all that. Ladies, you're wonderful. I just want to say one thing. I'm a family doctor. I'm a practitioner, and my wife is a medical employee as well. Last year, she entered the university to become a doctor because she didn't have powers. She wanted to grow. You're doing such a great thing, You're evolving, and I really want you to be successful. Andrei, I could never imagine the best motivation, the best final note of that, of that all. Your reflection is perfect. We are out of time.
Super. Питання?
Okay, a question. Great.
I would like to Oksana to ask a question. Can you name right now, or maybe not yet, some quantitative or qualitative indicators as a result of enhanced nursing implementation in your facility, or it's too early? Well, speaking about the numbers, if a doctor and a nurse as a team do preventive checkups for risk groups, so the maximum coverage of this population, if doctor and nurse would see the patient, that it means that they would spend too much time. So the nurse calls representatives of at-risk population and then put some red flags for a doctor, and then doctor continues. So the ability to ensure maximum coverage, that's what we do. And I heard in other PHC centers, then we may introduce some KPI based on the team performance, having the registries of this or that interventions. But as for the start, we just develop some best practices. Yes. I would like to add a few words. So if your PHC facility in your community will work with us on enhanced nursing role, then I would like to let you know that Oksana will be a trainer in one of the trainers' teams. So you will be able to interrogate her. And in conclusion, I would like to say the following. So Vlad said that we are infected with the change virus. I hope that we infected you all with the independent nursing virus, and I believe it's a good thing. Thank you. Thank you for the questions, thank you for the answers, and many thanks to our panelists for the great atmosphere and for the enthusiasm and for really nice discussion. So let me sum it up anyway. So what I understood from this panel discussion, well, there is the initiative, there is experience, there are implementers. That's half of the way, and we have trust. Okay, thank you so much. And so, dear panelists, please take your seats. Applause. So we'll keep it up. And some final remarks. While you're all here, as for tomorrow, the representatives of communities will work. You all know who stays for tomorrow. For many participants, the conference is over today. And I would like to mention that tomorrow between 9 a.m. and 9:30 a.m. we have the registration. And then we start at 9:30 a.m. So those of you who work tomorrow, please be here at 9 a.m. So let us sum it up. So I would like to see the final slide on the screen. So I will read it out for you, to be brief. So, the national stakeholders and international partners share the vision about the implementation of integrated approach for reconnecting people to quality healthcare. Coordination of efforts at all levels. The pluralism of thoughts. The human-centered service delivery model. Multidisciplinary teams for both decision-making and implementation. Ensure best health outcomes for the Ukrainians. International technical assistance helps to introduce best care delivery practices in line with the global experiences. An important prerequisite for those processes is an active engagement of communities in disseminating best practices during the war. And I would like you to applaud yourselves, I mean the representatives of communities. The integrated model that I promoted today, in this model, a PHC has to play a critical part, as it is the closest to a patient, and it plays a key role in care delivery and unites different specialists. The close interaction between healthcare facilities, primary healthcare facilities, and social care providers ensure the continuum of care at the community level. Next.
Розширення ролей медичних.
Enhanced role of nurses creates new channels of communication with the health system, which becomes closer to the patients, improves the quality of life and well-being of Ukrainians. And finally, we have an efficient way to control smoking. So, another approach is another principle is related to the barrier-free society. And this is one of the guiding principles for building back better. So, in cooperation with international partners and donor organizations, all other partners should focus on integrated approach to be able to introduce human-centered care model, strengthening the cooperation of their healthcare facilities, primary healthcare facilities, and develop close coordination as part of the intermunicipality coordination. Ladies and gentlemen, thank you so much. We worked quite efficiently today. And finally, the best news for today. I let you go, so you can have the final coffee break for networking and mingling.
Ось ці зв'язки, нетворкінг,
So, keep communicating. Have a nice evening. Have a delicious coffee and great networking. Goodbye.